Good morning. Welcome to this Open Minds, Healthy Minds Symposium. This event is going to be, there's some audience here, but it's being webcast simultaneously, so good audience all over the place. And this series is sponsored by Healthy Minds Canada, which is a group of charitable organizations that support research in the area of mental health. And it is being simultaneously hosted across the country in many cities from east to the west, from here to Toronto to Winnipeg to Vancouver and on the east coast as well. So it is the series that's been designed to have an interface between the scientific community and lay public so that we can share information about what's happening in the field of mental health, what are some of the cutting edge technologies that are influencing the delivery of healthcare and influencing the outcomes. And so today's theme, as you know, is brain stimulation in field of psychiatry. And this is where a lot of new and very important discoveries are taking place. We've been using some form of or other of brain stimulation for a long period of time, starting from ECT, the electroconvulsive therapy, which you'll hear about as well today, to now deep brain stimulation, where we're actually specifically stimulating certain areas of the brain to try and alter the outcome of mental health conditions. So it's a very exciting area, shedding a lot of light under not only in the outcome for patients immediately, but also helping us understand how brain works and how it is wired and connected and what goes awry at different times when you succumb to different mental health conditions, so depression in particular. So you have the program in front of you, you have the bios of the speakers with you. I just wanted to give you a bit of lay of the land for today. So this event here is being sponsored by the University of Ottawa Institute of Mental Health Research, which is the research arm of the Royal Ottawa Hospital here. I'd like to say a particular thank you to Dr. Berlim and Jennifer Hayes, who have been doing the coordination of the event for today locally. We extend our thanks to the lead coordinators and speakers. In particular, there's a very top of the line speakers that have very busy schedules, so thank you all for coming here today. And I also wanted to tell you about the housekeeping issues, in the sense that the program is in front of you, so I don't need to tell you where the breaks and stuff are, but if you need to use the washrooms, the exits are on either side of the building, and right outside the hall there are signs to the washroom if you need to use them, and of course you have coffee and muffins and stuff like that outside when you need. So without further ado, I'd like to begin the session, and first I wanted to tell you about the first speaker. And our first speaker is Dr. Marcelo Berlim, who comes from Montreal, and I'm just trying to get my notes on him. Just give me a second. That's funny. Oh, I dropped them. There they are. Thank you. So Dr. Marcelo Berlim has done his medical training in psychiatric residency and master's degree in psychiatry in Brazil. And after moving to Quebec, he did his clinical research and fellowship in mood disorders at McGill University. Dr. Berlim is currently an assistant professor at the Department of Psychiatry at McGill University. Is the director of Neuromodulation Research Clinic and a staff psychiatrist at the Depressive Disorders Program at the Douglas Hospital that is also associated with McGill in Montreal. He's also a clinical research scholar and supported by the Fonds de Recherche de Québec, which is Santé, FRSQS, and is recipient of a prestigious 2012 NARSAT Young Investigator Award. Dr. Berlim's medical practice focuses on management and treatment of treatment-resistant depression disorders, and his research interests concentrate on novel use of modulation, neuromodulation, that is brain stimulation, techniques in treating psychiatric disorders, as well as the cutting-edge neuroimaging and neurocognitive processes. And he's going to spend some time talking about a technique that has been around for the past few years, is RTMS, which is repeated magnetic stimulation, transcranial magnetic stimulation, which is sort of a non-invasive procedure to stimulate certain areas of the brain. So without further ado, Marcelo.
Well, first of all, I'd like to thank the organizing committee for setting up such a nice event. I have a tough mission today, which is to replace Dr. Daskalakis, who is a great presenter. I'll try to do my best. I don't know if the presentation will be... So, contrary to several of my colleagues who often practice their presentations, I don't really have the habit, so I usually expect my presentation to last for the amount of time that I've been allotted. So hopefully in 45 minutes I'll be able to finish the presentation. No?
The last few.
Okay. Well, as a friend of mine used to say, computers were invented to solve problems that didn't exist before the computer was invented. So let's see. Let's wait a bit. Okay, now it's thanks. Okay. Perfect. So my goal today will be to talk to you a bit about repetitive transcranial magnetic stimulation, as was mentioned in the beginning of the presentation. So as you can see, the other name that is used is magnetic brain stimulation, transcranial magnetic stimulation, and now there is a new form of magnetic stimulation that is called deep transcranial magnetic stimulation that I'll talk a bit to you in a few minutes. So these are my disclosures. I'll just leave it for like a few seconds so you can check. The main conflict of interest that might be perceived is that I received research support, which was initiated by myself and my team in Montreal with Brainsway, which is the company that is responsible for the deep TMS machine. So bear in mind when I talk about it that I've been funded by the company, not for speaking to them or voyage or like traveling for events, but mostly for carrying out research. So the first thing I'd like to talk to you a bit is about the impact of major depression in Canada. You can think about the impact in the world, and it pretty much resembles what we see in Canada. So the lifetime prevalence of depression in Canada is 12.2%. So this would mean that around 4.3 million people in Canada are or will be depressed at any one time, if based on current statistics in Canada. So depression in the past year is almost 5%, which means 1.7 million people. This is just a crude estimate. If you think about the past month, around 2% of people have been depressed or are depressed for the past month, and this is all like over 500,000 people. And if you think that around a third of these patients, of these individuals, will have a chronic illness, you're talking about a huge number of patients who have a very, very significant illness, will limit their lives to a significant extent. There are like tons of studies showing how resistant depression, so-called treatment-resistant depression, can increase healthcare costs to like 5-10 times. increases mortality, increases suffering, not only for the patient, but for the family, for society as well. So interventions for depression, particularly the resistant depressions, are of paramount importance in clinical psychiatry and in mental health in general. So this is just to give an idea about what happens to the typical depressed patient when he or she is treated either in a specialized clinic or in the by a general physician. This is a big study called the STAR-D study that was published in the past 5-6 years. It has been conducted for probably the last decade when it was started. And the idea here is that they got over almost 4,000 patients who were assessed for being treated for depression, and these patients were offered several steps of treatment until they got better or until the study finished. So in this study, there were 4 different steps of treatment that would last several months. I mean, you would try the first intervention, then you could try a second one, a third one, and a fourth one. And this covers, all the interventions that were offered covered a significant range of the things that we have available in psychiatry for treating the depressed patients. So I think that my main message here to show you is that if you consider like the typical depressed patient, after the first treatment in this case was citalopram, a very common antidepressant, over half of the patients were still quite symptomatic after this first treatment. And if we consider the remission as the gold standard for treatment, remission being the almost absence of depressive symptoms, you can see that almost 2/3 of the patients were still symptomatic. And we know that patients who remain symptomatic after treatment will have a harder time to get better afterwards. And if they improve significantly, but they don't have this so-called remission, they have higher chances of relapsing, of being depressed again. So this is just to show you here what happened. So for those patients who did not improve significantly in the first phase, they were offered additional steps which could be combination of medications, for example. And you can see that gradually the rates of improvement, the response, which is an improvement of at least 50% in the symptoms, and remission, they start going down up to a point in step 4 in which you have the large majority of patients would remain depressed even after trying several treatments. So this is just to mention to you why we need different approaches, why pharmacology and psychotherapy, while they are very helpful, they are not really enough to treat perhaps 15-20% of the patients, sometimes some estimates perhaps even more, but to be conservative, let's say 15-20% of the patients who try a lot of treatments and still remain very much symptomatic. That's why, one of the reasons why neuromodulation or brain stimulation is becoming very popular is because it offers a different way of treating depression and a number of other psychiatric illnesses. And the neuromodulation or brain stimulation techniques have been divided in 2 big families. The non-invasive ones, which means that you don't really have any sort of surgery, you don't enter inside the brain physically. I mean, you enter physically, but not, with your hands, with electrodes or anything like this. And you have the so-called invasive techniques in which you actually have to do some sort of surgery. For example, either in the neck for vagus nerve stimulation or inside the brain with DBS, with deep brain stimulation. So I'll be covering today in my presentation the repetitive transcranial magnetic stimulation or RTMS, the deep transcranial magnetic stimulation or deep TMS, which are both non-invasive. Afterwards, Dr. Sackeim will talk about ECT, so electroconvulsive therapy. And Dr. Lozano will be talking about deep brain stimulation. So you'll have a nice view today of the non-invasive and invasive neuromodulation techniques. So I think it's a neat combination that moves from the less invasive to the more invasive. So what are the principles of RTMS and deep TMS? So I think the first thing when patients come to see me and they say, are you going to put like a big magnet in my head or something like this? So even though we use principles of electromagnetism, it's not really, we don't have like a big magnet. We have like an equipment that I'll mention to you, that I'll explain to you afterwards, but it's not really like putting a magnet that you can buy anywhere. I mean, it's a pretty expensive equipment that is given in a very specialized way for patients. So I'll be focusing mostly on RTMS or the standard TMS, which is the initial form that was developed, and I'll be talking a bit about the deep form of TMS, which is a more recent development, and I'll try I'll try to remember every time to point out that there are differences between them. But mostly, what I'm talking here serves for both of them. But my focus is really on the standard TMS, which is the most commonly used technique. So we think about the historical background. If you look back in time, I mean, and this you can look back for the 19th century as well. People have been trying to play with magnets and electricity to affect brain functioning for really a long time. And as you can see on the two first pictures here, these are examples of researchers who try to develop this big magnets, these chunky magnets, to create visual phenomena called phosphenes. So if you put yourself, for example, in this picture, this is Thomson in 1910. So when he put his head in the middle of this big electromagnet, he could see some sparks of light. Stop hands. Okay, I'll stop my hands. I'm Brazilian, I mean, so I have to keep my hands low. It's going to be hard. Okay. So 1910. So that's when he put himself inside this equipment to try to see the phosphenes. But the problem is that, and you can see 1914, something a bit more radical, but again with the same objectives of influencing brain activity with electromagnetism. But the problem was that the equipment was not really good to store the amount of energy necessary to release the energy necessary to really have a more precise activity in the brain, to really affect the activity in the brain more precisely. So it wasn't before 1985 in England that Barker and his colleagues developed the first actual TMS machine, transcranial magnetic stimulation machine, so which could store the amount of energy necessary, release it, and affect brain activity in a very clear way and reliable way. So, and if you think that 1985 was when the first machine was developed, 1993 was when the first treatment was ever administered, at least published. So a couple of case reports by Hofflish in 1993. So it's a pretty recent treatment. If you think about ECT, which is from the 30s, TMS is quite recent, and deep TMS is even more recent than that. The main difference from if you look at this equipment, Barker's equipment, is that his equipment could only give one pulse at a time, couldn't really give many pulses, and so the clinical use was not as relevant. It was more used for probing neurofunctioning, and motor cortex, for example, was you could study the motor cortex with this technique, but it took the field a few more years to be able to develop the machine that could actually give many pulses in sequence, so the repetitive part of the treatment, which then can be used to treat a number of illnesses, both psychiatric and neurologic. So the equipment is quite simple. You have here an example. You have a big machine that stores energy, that have large capacitors. We have a triggering mechanism that will release this energy very fast, that will go to the stimulating coils. You have here in the middle, you have the figure of 8 coil, which is a traditional coil that is used for in psychiatry and for clinical interventions. This is for the standard TMS. You have on the right side, on the right corner, you have the helmet that is used for the deep version of, or the deeper version of TMS. So they really differ in terms of the coil that you use. And the coil is a pretty simple device. You have like rounds of copper, for example, usually copper that are rounded. They are placed inside this plastic cover, and they are the ones who the coils are the ones who will receive the electric current, and then will because of the presence of the currents will produce the electromagnetic fields. But I'll talk about it a little later. So the magnetic field that is produced by this equipment is around 1.5 to 2.5 Tesla, which is more or less what you see in magnetic resonance imaging equipment. The main difference being that in the MRI you have this on all the time. The magnetic field is there all the time. And with RTMS you have the pulses were very, very brief, 250 microseconds. So the exposure to the magnetic field is really, really quite small with RTMS. So the principles, the mechanism of action, even if we don't know, we don't know yet exactly how it works. There are several theories and several studies going on, but we know the basics of how it's supposed to work. So it's based on the electromagnetic induction by Faraday that was discovered or described by Faraday in 1831. So the principle is pretty old. There's nothing really that fancy about it. So in a nutshell, what the treatment does, what TMS does, is that once you release the current through the coils to the figure of 8 or the helmet coil that I mentioned to you, this currents will in turn produce a magnetic field that is tangential to the current. So you can see there in red you have the magnetic fields, in black you have the electric fields, and these magnetic fields will cross the skull unimpeded, so they won't really be affected very much by the skull. And when they get in touch with the brain, they will be able to induce an electric current in the brain. And this electric current has the potential to produce action potentials and change the activity, change the way the brain works, or change the brain activity. So with TMS, we can either enhance or increase or excitate the brain, or we can inhibit the activity depending on the parameters that we use, and I'll mention the basic ones for you in a few minutes. So this is just to give you an idea of the difference between the RTMS, the standard one, using the figure of 8 coil that I mentioned to you, a butterfly coil, versus the deep TMS, or the deeper TMS. On the top here, you can see when you put the equipment, the coil. This is not actually in the brain. This is done in phantom. The structure is a phantom brain, which is something that tries to resemble a head, has a fluid inside. So they haven't done this in humans. This comparison yet, and we are trying to do that in Montreal now in one of the studies that we're carrying out. But as you can see here, the main difference between RTMS, or the standard TMS, and the deep TMS is that deep TMS it affects a larger volume of brain area, and it goes deeper in the brain. So as you can see by the pictures in the first one, around 1.5 centimeters you still have some effect of the RTMS coil. Around 2.5 it becomes really faint. So meaning that you can go down, you can get inside the brain for about 1.5 centimeters, 2 centimeters perhaps, with the standard TMS. And the deep TMS, as you can see, the area that is affected is much larger, and it goes deeper. So if you go up to 4.5 centimeters, you can still see some activity of the coil in the brain. So you could probably more or less double the depth of stimulation, but you multiply the area by probably 2-3 times at least, the volume, by 2-3 times. So the theory behind it, and it's still not, there's no study really testing it, is that because deep TMS affects a larger volume of the brain and goes a bit deeper inside the brain, that it will be more effective for treating whatever illness TMS is able to treat. It would treat better. But this is really speculative. There's nothing really confirming this. No direct comparison between the standard coil and the helmet for deep TMS. But again, deep TMS is another way of treating depression, for example, and so it's a nice addition to to what we can offer to patients. This is another way of seeing the same concept. So you can see that the RTMS, most of the simulation is on the surface, and you still have some sort of spread, but it's quite focal. And with deep TMS, you have a much larger volume of the brain that is affected, and it goes deeper inside the brain. But again, is the fact that the deep TMS goes deeper related to a better efficacy? We don't know yet. So, of course, the company behind it, is marketing the device as being. Here I go with my hands, so I'll keep my hands down. So the company is marketing as being more effective, or theoretically more effective. But I'll just reinforce, we don't have any really good study comparing both of them to say whether it works really better, deep TMS or not. So an important thing, what is the official status of deep TMS and RTMS in Canada? Most people are not aware, or some people are not aware, but both of them, RTMS and deep TMS, are official treatments. Both approved by Health Canada, RTMS in 2001 by Health Canada and 2008 by the FDA. So you can consider it as official as a standard antidepressant for treating depression. Deep TMS is a more recent development, so in 2013 it was approved by both Health Canada and the FDA. So it's an official treatment. So what are the principles? And again, I'll be focusing here more on RTMS, and I'll try to point out how deep TMS differs from RTMS. So this is a common setting, common treatment setting. This is not our setting, but our setting just has a different chair. But you have the equipment, you have the patient sits down on a comfortable chair. You place the coil in the head in the area that will stimulate. I'll talk to you a bit later about how we select the area and how we identify it. And then the machine is programmed. The patient stays awake. There's no anesthesia. The sessions will last for 15-30 minutes, and then after a few minutes the patient goes home and comes back for more treatment. So the site of stimulation, how do we choose the site for stimulation in depression? The most commonly used sites are the left dorsolateral prefrontal cortex and the right dorsolateral prefrontal cortex. So as you can see in the picture, they are located in the front of the head on both sides. The reason why they have been chosen is really based mostly on imaging findings or neuroimaging findings showing that depressed patients have lower activity on their left side of the brain, on the left dorsolateral cortex compared to healthy controls. And on the other hand, they have some sort of a hyperactivity on the right side of their prefrontal cortex. So what you aim to treat with TMS in depression is to speed up a bit the left prefrontal cortex and slow down a bit the right prefrontal cortex, and that's the rationale. There are other regions that are being studied recently, but by far left and right dorsolateral prefrontal cortex are the ones that have been really that have been studied the most. So how do we locate these areas in the brain for treatment? There are at least 3 ways of doing it. The first one is called the 5 centimeter rule, which basically means that you will find the motor cortex, and then you will calculate 5 centimeters anterior to the motor cortex to place your coil. The problem with this 5 centimeter rule, which has been used by many studies, is that when you try to see exactly what you're targeting with imaging, for example, for like at least a third of the patients who receive the treatment, you're targeting completely different areas. So it's not a very reliable way of identifying the dorsolateral cortex, prefrontal cortex. So another way of doing it is using the 10-20 EEG system. Is something that is used when you're going to place EEG electrodes in the head. So it's a pretty standard and common approach for placing electrodes. You can use more or less the same landmarks to locate the right and left dorsolateral prefrontal cortex, which correspond to the F3 on the left and F4 on the right side. More recent, this seems to be better overall than the 5 centimeter rule, but it's still not perfect, or still not very incredibly precise. So most recently, there has been developed a new way of targeting the cortex. Not only, any area that you want. In fact, is called neuronavigation. So what it is, neuronavigation? You get the patient inside an MRI scanner. You get them for 10-15 minutes of a structural brain imaging. So you get the picture of the brain. You put this image inside a specific software that is connected to the coil through an infrared system. And at the end of the day, you can actually locate the coil inside the brain based on the patient's anatomy. So you can be incredibly precise because you look into the picture of the brain and you place the coil above the region that you want to stimulate. But the main problem is that you need to have a magnetic resonance imaging scanner available, and you need to pay for the scan. So it's not really something that is clinically very much used. In Montreal, we use the 10-20 EEG system. Sometimes we use neuronavigation, but mostly the 10-20 EEG system, which I think is a good compromise between them. So the frequency, as I mentioned to you, with RTMS, we can either activate or inhibit brain activity, and this is done mostly by the frequency that we give the pulses. So the frequency is measured in hertz. So 1 hertz means 1 pulse per second. 5 hertz means 5 pulses per second. So we know that when we use 1 pulse per second or less, we're able to inhibit brain activity in most areas. This is not really valid. There are some studies showing that depending on the area of the brain or depending on the baseline brain activity, you could actually enhance brain activity with low frequency, but mostly it has an inhibitory effect. So 1 pulse or less per second, and it's really 1 pulse is like tup, 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 and that's low frequency RTMS. High frequency RTMS is usually from 5 hertz up to usually 20, but you can go to as many pulses as your machine really can administer. 5 hertz, 5 pulses in 1 second, 20 hertz, 20 pulses in 1 second. So the more you move up, higher in the frequency, you have a session that goes like trrr. So you receive is really several pulses. For example, a common approach is 10 hertz in 4 seconds. So you have really 40 pulses that are given in 4 seconds with a period of an interval of usually 26, 27 seconds. And this is repeated again for 75 times up to 85. Commonly it's 75 times. So what the patient feels is really a few seconds of active stimulation, like a woodpecker. That's what how patients describe the sensation. For a few seconds, and you have most of the session is then really nothing happens for most of the session, because you have for every 2-4 seconds of stimulation, you have at least 15-25 seconds of repos, of rest. So when you combine frequency with the location, we have the 2 most commonly given protocols for major depression. So we usually use the high frequency RTMS on the left dorsolateral frontal cortex. Again, we want to enhance the activity on the left dorsolateral cortex. We use low frequency RTMS, so 1 pulse or less per second on the right side, because we want to slow it down a bit. That's the rationale for using both of these approaches. And some studies have tried to combine them. So you give a bit of high frequency on the left side, you give a bit of low frequency on the right side, and the results are encouraging. It doesn't seem necessarily to be better than when they are separated, but it's a different way of administering. So in the same session, you get a bit of each one of them. So the intensity, this is an interesting and important point, is that in order to individualize treatment for each person, we use an approach called the assessment of the resting motor threshold. It's a pretty simple, sounds fancy, but it's a pretty simple approach. So what we do in order to identify what is the amount of intensity that we'll give to each person, we place the coil, the magnetic coil or the helmet, in the motor cortex, in the primary motor cortex, and we give individual pulses to this area, and we try to identify hand or wrist movements. So you start with a percentage of the so the equipment works from 0 up to 100%, the amount of energy that it can deliver. So you start with a higher amount, let's say 65%, 60%. You give an individual pulse, you see if the hand twitches. If the hand twitches, you go down. If it twitches again, you go down, and you find the place, the moment where the hand stops twitching. Or in fact could be either the thumb or the hand or the wrist. I mean, nowadays, in the beginning, it was really mostly they were looking for the thumb. Nowadays, because of it makes things a bit faster and doesn't seem to really make things more risky for the patients. We look really for any sort of movement in the hand. So when you want to administer TMS on the left side, you'll see the hand movement on the right side, and if you want to administer on the right side, you'll see the hand movement on the left side. So once you identify this threshold, you can calculate an amount of energy based on this threshold that in depression studies has varied from 80% of this value of the motor threshold up to 120%. 80% in the earlier studies when people were more cautious and they didn't know exactly what sort of effects it could have or in terms of safety. But more recently, the studies have usually used from 110% to 120%. So let's say that your motor threshold is 60% of the machine. So above 60% your hand twitches, below that your hand doesn't really move. You calculate 20% above that, and that's what you use for the treatment. So in this case, 72%. We can, for example, for patients who are more sensitive, we can adjust this intensity. So for some patients who cannot tolerate 120% right away, we can start with 100%, go to 105% in a few days. So we have ways of accommodating this for patients. So this varies a lot between patients and between healthy people as well. So that's why you have to do this, because the motor threshold for a person can be completely different from someone else, from one person to another. And medications have an impact on that as well. And what we know is that with time, the motor threshold tends to go down. So the first week of treatment, you have a motor threshold of 60. Second week, you might have a 57, for example. So it's important for us to be repeating that every week or so, every 1 or 2 weeks. So we want to keep the treatment as safe as possible for patients. So other parameters of treatment are pretty clear. We can choose the amount of magnetic pulses that we give per session. The initial studies have used 100 pulses or even less. Nowadays we have 3,000 pulses or more. So each person receives 3,000 clicks or 3,000 magnetic pulses in one session. We have a protocol now in Montreal we're finishing in which we're giving 6,000 pulses in one day for patients in half of the time to see if we can speed up a bit the effects of the treatment, and the results are really interesting. The number of sessions, usually from 5 to 30 sessions, like the typical treatment, so from 1 to 6 weeks. I can tell you that from as pretty much, I think with everything in medicine and certainly in psychiatry, we start very careful, and with time we start giving in more and seeing that perhaps administering higher dosages of medications, for example, or giving more sessions of a specific treatment, it can make them work better. So the first studies have used from 1 session to 5 sessions on a daily basis. So this is given once a day. In the study that we are finishing now, it's twice a day, but it's usually once a day for the number of weeks that you're giving. So usually between 4 and 6 weeks of treatment. So from 20 to 30 sessions mostly. So the treatment is given, again, I'll just reinforce, is given on a daily basis for that number of weeks. So it's important when patients are referred that they realize that this is a time-consuming sort of intervention. Some people think that it's one session and you go home and it's done. No, this really takes several weeks. So the patient has to be available to really come to the center and stay for an hour at least a day for treatment. So each session, depending of course on the parameters, the more pulses you have, the longer the session will be. But usually with the common parameters, the most standard parameters, you usually have a little less than 40 minutes per session. And as I mentioned to you, we usually require patients to arrive 5-10 minutes before the session, and we ask them to stay for the 15, 20, 30 minutes afterwards just to make sure everything's fine, and then they usually go back to their daily activities without really any trouble. So the contraindications for RTMS. The major risk of RTMS is to produce a convulsion. And this is for ECT, that's what you're looking for. That's part of the therapeutic process. In RTMS, is a non-convulsive approach, so you want to avoid it as much as you can. So people, like individuals with a clear history of convulsions or epilepsy, are usually not good candidates for RTMS. Even though, as I'll mention in a few minutes, there have been very, very little, very small number of cases of convulsions worldwide. So it's really not a big concern, but I mean, you better safe than sorry. So if you have a major brain disease, like a tumor or stroke, a recent problem like this, you would be careful and maybe, not administer the treatment. If you have a severe head trauma, you have a major car accident 3 months ago, I mean, maybe TMS is not really the best thing for you, because all of this, both major brain diseases and severe head trauma can increase the risk of epilepsy, for example, of a convulsion. If you have increased intracranial pressure as well, if there is some sort of problem in the brain and the pressure inside the brain is too high, you're usually not a good candidate as well for TMS. If you're using drugs or alcohol, this can decrease the threshold for a convulsion, so we are also especially careful with that. And if you have metal, any sort of metal in your head or eyes, you shouldn't do it, because TMS is a big magnet, so if you have a metallic thing inside your head, it's going to be attracted by the coil and it could produce significant damage. So we usually don't accept patients who have, for example, aneurysm clips in their heads, and we ask patients with cochlear implants, so hearing aids, to take them before the session. But fillings in the teeth, I mean, something patients often ask me, there's no problem, it's too far from the coil to have any sort of impact. So it's really eyes and brain. So the side effects, seizure, as I mentioned to you, is the worst problem. We only had 18 cases worldwide. Perhaps nowadays, a couple of more cases in the past 5-10 years. So let's say, being very conservative, like 22, 25 cases out of at least, I mean, it's a very conservative estimate of 90,000 sessions or more, probably more than that. 90,000 sessions, only the ones that have been published. So if you think about people who have not published studies on the use, you're talking about probably hundreds of thousands of sessions. So it's really, really small, the risk of someone having a convulsion. And it's so rare that you can actually publish a paper on it, because it happens so rarely. The patients who had convulsions, they usually had risk factors for that. So they were either taking medications that were known to increase the risk of convulsion, or they had neurological diseases that were associated with a higher risk of convulsion. So it's rare for you. I mean, I don't think there's ever been described, as far as I'm aware, a convulsion in a healthy person with no risk factors for convulsion. So in 1998, there's a group developed safety guidelines for the use of TMS, and since then there have been probably a couple of cases of convulsion. So again, the point is that it's a pretty safe treatment overall. The fact that the coil not only is very far away from the heart makes it very safe in terms of cardiovascular impact. So there's nothing really that goes there's no effect on the heart functioning. When we have to use earplugs, because the clicks, the magnetic pulses are quite noisy, so patients and technicians use earplugs, but with earplugs there's no hearing impairment for patients. There have been no cognitive or neurological deficits described in patients who have received TMS, sometimes for many months. But this is short and medium term, so up to 2 years, perhaps 3 years nowadays. But we don't know exactly what happens in the long term, let's say 5-10 years after a treatment. But all the evidence points to the fact that TMS is either neutral or might be even beneficial for cognitive functions in depressed patients. For example, there are several studies showing that depressed patients before and after TMS, after TMS, they have some sort of enhancement in their cognitive abilities, for example, memory or planning abilities and other sorts of cognitive functions. So it seems to be either neutral or beneficial for cognitive functioning. The most commonly reported side effect is a mild to moderate tension-type headache, which usually happens just after the session, but tends to get really, patients tend to become very capable to tolerate the treatment very fast. So after a few sessions, people are usually, I remember a few patients that started treatment with us, very anxious, very tense, shaking and sweating. And after a few sessions, they were pretty relaxed, almost falling asleep. And this has been described in the literature. So for some reason, people develop this sort of like resistance to the pain or to the annoyance of the treatment in a very fast way. So we can treat the mild tension type headaches with aspirin, with Tylenol. So it's not really a big problem. Most of the studies have shown that less than 10% of people drop out of TMS treatments because of side effects. So, looking at the glass half empty, over 90% of people who start will finish the treatment, which is a very good dropout rate. So the exposure to low-intensity magnetic fields has been shown, even recently by a large meta-analysis, to be very safe. So, even technicians administering that on a daily basis and patients receiving it for a few weeks, there is absolutely no risk, according to current evidence, that this will have any sort of effect, like deleterious effect to their health. So I'll talk a bit now about the efficacy and acceptability of RTMS and low-frequency RTMS. Efficacy, I'll be focusing on the two major outcomes that I mentioned to you. Response to treatment in depression, which is an improvement of at least 50% in the symptoms from baseline to the end of the treatment, and remission, which is the almost absence of symptoms. So patients might still have some symptoms, but most of the depression is gone. And acceptability, which is how many people who start a treatment end the treatment, regardless of the reason. So it could be for side effects, because they moved to another city, because they are not really in the mood for continuing with the treatment. So it's a general way of seeing how acceptable the treatment is for the average person. So the results I will present to you here are based on several studies that our group in Montreal has done. So what we have done, I don't know if you are familiar with, is a type of study called a meta-analysis. So meta-analysis is a way of really searching the literature for everything related to a particular subject, in this case like TMS for depression, and putting everything together, compiling everything, and coming with an estimate that takes into account how big were the studies and how small were the studies. So it's a way of really trying to get to the best evidence available for each treatment, in this case for RTMS. So we have done, the first one was high-frequency RTMS, so 5 or more pulses per second, given in the studies, when you put everything together from 5 sessions up to 30 sessions, the mean number of sessions was around 12 sessions. So the results here are based on a mean of 12 sessions. So if you think 12 sessions, you're talking about 2 weeks and a couple of days. So not a lot, not a long time for the results that we see here. So this is a compilation of high-frequency RTMS when it's used to enhance the efficacy of antidepressants who are not really working very well, or when it's used alone as a treatment for major depression without anything else combined with it. So the results that we have is that the response, so the number of patients the percentage of patients who have at least a 50% improvement in their depression is around 30%, a third of them. An important thing to mention to you is that most of the studies have included patients who had already done the second step of treatment overall, so they were pretty resistant overall already. And I won't go back because we don't have time. But if you take a look at if you remember the results that I mentioned to you from step 3 and step 4 of the big STAR-D study that I mentioned, the response and remission rates are half of the ones that we see with RTMS. So this is an indirect way of saying that is at least as effective as pharmacology and probably cognitive therapy, behavioral therapy, which was used as well in STAR-D. So 30% of patients receiving real TMS have a response versus 10.5% with those who receive the so-called sham treatment, which we try to resemble the active treatment, but actually doesn't give any treatment. So it's a way of having a placebo comparison. So this is a very significant difference from a statistical point of view, but this implies as well that over 70% of patients will have maybe a small improvement, but won't attain a response. So points to the fact that we need other sorts of interventions, and I think that's where ECT and DBS come in the picture. So the other measure is remission level. So again, the almost absence of symptoms. You have around 19% of patients, so a fifth of the patients who attain a remission after 2.5 weeks of treatment, versus 5% in the sham, in the placebo group. Also 20%, you might say, okay, 80% of patients do not attain. That's right. But this is probably at least as equal to, or probably slightly better than what you see with the traditional pharmacological treatments. The main difference being that this is, again, on average after 12 sessions, and medications we usually talk about several weeks of treatment, perhaps a few months of treatment to attain similar results. It's important to mention as well that these are acute results. I mean, I'm talking here about what happens when you start a treatment, you just finish a treatment, what happens? The next big important question is what happens afterwards. I mean, is this something that will stay, will last? And I'll mention this briefly in a few minutes. So dropouts, that's an important thing. So when you compare those who received active treatment versus those who received the placebo treatment, the number of people who left, who didn't continue with the treatments were similar. So meaning that standard TMS seems to be pretty well tolerated, the same as sham. So people will get out of the studies in the same rate between both of them. So this is we don't have lots of studies. That's an unfortunate thing. We don't have lots of studies on the long-term effects of the treatment. This is the largest one that is being published now by Carpenter and her colleagues in the US, showing what happens after 1 year of treatment. So you did let's say 4 weeks of treatment, traditional treatment, and then they followed up patients for up to a year. And in 1 year, so from 257 patients, almost 70% of them were still in response, maintaining a response, so at least a 50% improvement compared to their baseline. Almost half of them were in remission after 1 year, which is a pretty nice finding. But you could look as well to say, okay, maybe half of them had relapsed, yes, the half of them had relapsed and might have needed more TMS or other sorts of treatments. And you could still see a significant reduction in symptoms of depression, of course, from baseline up to 1 year, but also improvements in quality of life compared to baseline. So it seems to have an enduring effect, even though the sessions, again, the course of treatment lasts a few weeks only. But we need more studies, for sure, to be able to better assess the long-term efficacy of TMS, in this case, effectiveness. So this is, I'll try to go briefly, I think I have probably 7 minutes to go. So this is another meta-analysis that we did, trying to assess whether the combination of high-frequency TMS with antidepressants at the outset could speed up the improvement. So instead of starting with only TMS or starting with only antidepressants, the studies have started them together and then have seen if they can speed up, if this combination can speed up the results, the improvement. So one group received antidepressants plus active high-frequency TMS. The other group received antidepressants plus the placebo or the sham TMS. So these are the results. The results were measured in 2 different times. So the first time that the results were measured were as soon as the TMS intervention finished. So the average number of sessions here was probably around 15 sessions of TMS. And the next time that the patients were assessed was 8 weeks into the treatment. So you would see the acute effects of TMS as soon as it finished versus the longer term effects of medication plus whatever effects that TMS has given. So these are the response rates of the improvements, at least 50% improvements from baseline up to 3 weeks. For those who received active treatment, active TMS plus antidepressants, there was almost 50% of them who presented a response versus 27% of them who presented a response with only antidepressants. So you don't double the rate, but you increase it significantly from when you compare them. So at time 2, meaning when usually in this case 7 weeks after the treatment was started, so the TMS was finished already by 4 weeks by then. You had response rates of 62% for the active combination versus 46% for antidepressants alone. And remission rates, you had 54% versus 38.5%. Both are significant differences. And so what does it mean is that perhaps it's a good idea if you have available to start TMS together with antidepressants, you probably have a better result than only antidepressants given for depression. So dropout rates as well, and also an interesting fact, and then that patients left the studies at the same rate between those who received active or placebo sham treatment. So it seems to be an acceptable treatment. So low frequency TMS, if you remember, high frequency on the left side of the brain, low frequency on the right side of the brain, 1 pulse per second or less. This is another meta-analysis of low frequency TMS that when it was used to augment, to enhance the effects of antidepressants, not at the same time, but so patients were taking antidepressants and did not improve, and we want to boost the effects with something else, so with low-frequency TMS, or low-frequency TMS used as a monotherapy by itself with nothing else for treating depression. So as you can see here, response rates of 40%, 38% versus 15% for low-frequency TMS. They seem to be higher than with high-frequency TMS, but this, you have like many less studies than you had with high-frequency TMS. So I mean, you have to be careful with these indirect comparisons. But seems to be better than giving placebo for patients, significantly better. Remission rates of 35% versus 9% with sham, with placebo. So also quite significant. But again, still patients were, I mean, significant percentage of patients were still depressed and not well after the treatment. And the dropouts between the low-frequency groups, the sham and the active ones, were similar as well, showing that this is also quite acceptable. So how to compare this with antidepressants? There is no study to date that has actually compared our TMS with antidepressants alone, so one against the other. So we have to base our estimates on indirect evidence. So this is just to show you, I won't go really very much into detail here, but this is just a comparison of the most recent and largest meta-analysis on antidepressants for major depression versus what we found in our meta-analysis. So what we can say is that they are at least as equivalent as each other, but or if you're like you want to be less conservative and look at the numbers, you could say that perhaps high-frequency RTMS and low-frequency RTMS in the short term are perhaps a bit more effective than drugs, than medications. But this is an indirect comparison, and I would be careful. I think the most careful thing to say is that it's probably at least as equal as antidepressants and perhaps a bit better. But so that it's what the data show here. Even for the tricyclic antidepressants, which are considered sometimes the gold standard of treatment for major depression, for pharmacological treatment, the numbers that we have for high frequency and low frequency TMS are slightly higher. Again, indirect comparison. So this is another meta-analysis that we have done comparing, and this will be a bit, we'll touch a bit on Dr. Sackeim's presentation. So when you compare, so when RTMS was developed, several people thought that maybe this is coming to replace ECT. ECT has lots of stigma, even though it's still the best treatment for depression. But there's a lot of stigma. Very few people receive the treatment. Not every center has an ECT machine. So they say, well, maybe RTMS is going to come and will replace it. And some initial studies were encouraging. But when we have compiled the evidence for the best available evidence. And what we show is that ECT beats TMS significantly. As you can see here, remission rates, or the almost absence of symptoms in the studies that have compared them against each other, of 52% versus 33.6%. So I think that the best evidence nowadays is that with the current technique that we have, ECT is still better. And this is an effect size that shows the change in the symptoms of depression. So when you take a look at the scores in depression from baseline to after treatment, minus 0.9 is a very large effect size favoring ECT as well. So just another way of confirming the fact that ECT is better currently than TMS, and I'm not surprised by it because I think, as I'm probably biased. My experience with ECT is very good, so I was expecting to see that. I would be surprised if the studies really showed that TMS was better. I mean, it wouldn't really conform to my practice. An interesting thing as well is that high frequency TMS and ECT had equal dropout rates. One thing that I didn't cover here because we don't have lots of information about it is about the cognitive effects. So some people are scared about the ECT having some sort of negative effects on memory, for example. But the studies have shown that they are pretty much equivalent. I mean, ECT seems to be a bit more negative when it comes to the cognitive function that has been assessed. But after a few weeks or a few months of follow-up, patients usually got back to their usual. So there's not really a major advantage for RTMS compared to ECT when it comes to cognitive effects, but ECT is better clinically. So the last thing that I'll talk to you about is the efficacy of deep TMS. So as you may remember, the helmet, not the coil. So there is one large study that has been published, that is about to be published soon, about deep TMS. So deep TMS is a pretty recent development. If you take a look at RTMS, at the standard TMS, we have like 40, 50, 60 studies on it. With deep TMS, we have really only one big study that has been carried out. It's a study on 233 participants, and what this study has shown is that from weeks, so comparing the active treatment with sham treatment, is that after 3 weeks you already see a separation between the groups. that is maintained up to 4 weeks and increases at 4 weeks. It's maintained at 5 weeks. And they have some more recent results showing that when they reassess patients around 3 months, patients who received active treatment were still doing much better than those who received sham treatment. Another way of seeing it, this is less clinically interesting to see scores on a scale. I think it's more clinically relevant to see this like response and remission rates. As you can see here, when you compare the deep TMS with the sham treatment, it's 30% of remission versus 14.5%, which is not bad, considering that these patients as well, they had mostly used at least 2 antidepressants with no improvement before they were enrolled in the deep TMS study. When you take a look at response rates, 37% versus 20.5%. Both of them significantly different between each one of them. And this study has led the FDA to approve deep TMS as a treatment for major depression. So the last thing that I'll mention to you is, I think it's the million-dollar question: is when do you use RTMS and deep TMS for depression? I think that the consensus nowadays would be that you wouldn't wait too long for trying it. Unfortunately, the fact that this is a new technique and few people here have heard about it, it still makes, for example, doctors and patients to think that this is kind of like a last resort, a last hope sort of treatment, which is not. I mean, there are some interesting studies showing that the more resistant you are to treatment, so the more things you've tried and didn't improve, the more resistant you will be to RTMS and even ECT as well. So we recommend TMS for patients who have tried, let's say, 1 or 2 antidepressants and didn't really get better with the antidepressants given properly, good dosages for a good amount of time. Or for those patients, for example, I just saw this week a patient who tried, I think, 4 or 5 antidepressants but could not tolerate them, had like all sorts of side effects. So RTMS and deep TMS could be an indication for those patients who cannot tolerate medications, because again, you have to think that both of them are more focal. Medications are systemic; they will have an effect throughout the body and might give side effects everywhere. And deep TMS is really a more focused, and RTMS more focused. So after you try, let's say, 1 antidepressant, 2 antidepressants, you might be a good candidate for RTMS. But based on the evidence that we have, I mean, you should try RTMS before you go to ECT. And I might be spoiling a bit the presentation of Sackeim, but I think the idea nowadays is that you should try ECT earlier than later. I mean, don't wait until it's you've tried everything else and this is the last hope for the patient. So try it earlier. I think this is valid for lots of things in psychiatry. So that's my last. I hope that this has happened. I mean, I'll be happy if that's how you feel. I would have accomplished my mission. So thanks so much. And have a good day. Okay, you have a couple questions.
Couple quick questions.
Français ou anglais? Feel free. Yeah.
I'm just wondering, what do you recommend for maintenance treatment after a patient responds to TMS? Do you just have them, do they do any kind of booster TMS treatments, medications?
Yeah, so I mean, that's a very important question. I think that's also, I mean, we focus a lot, the research that we have is on like the acute effects. So what to do afterwards? I'd say someone got much better with TMS, so what do you do afterwards? This has been a problem with ECT, that has been, I think with the maintenance ECT, has been more or less, improved. So the problem is that we don't have lots of literature on that. So you have a few studies here and there showing strategies that have been used on how to really maintain the improvement that the patient has had. So in Montreal, what we do, and this is based again on the few studies available in the literature, is that for those patients who have really improved, so at least a response. So if your depression is doing at least 50% better than before, we offer the maintenance treatment, which is usually a couple of sessions a week for a few weeks, and we can offer also afterwards a few booster sessions as well. But this is really kind of like our approach to it, and I wouldn't really say that this is really the best one. But probably you will need, patients really need something to continue to do better, because chances are that they might relapse and I think a good analogy is that when you're treating high blood pressure and you're taking antihypertensive medications, if you stop the medications, I mean, the blood pressure goes right away. So if you treat depression with ECT or RTMS and the patient gets worse because you treat and you stop the treatment. So we need some sort of booster sessions, maintenance treatment, but the literature is still, not really clear. But just to reinforce, for those patients with a significant improvement, we offer maintenance protocols for them, and we are developing now a small study comparing two different protocols to see if we can get something that works better clinically.
Okay.
You mentioned that the treatment has been recently approved by Health Canada and FDA. Has it been approved across all the age range? What about adolescent or elderly people? And are there any studies that have been done in this age range? Any specific side effect or specific risk?
Perfect. So I mean, the approval is for adults. There's no really. So then I'll answer your second question. I mean, there have been some reports, some small studies in adolescents. In children, I'm really not aware of. But in adolescents, yes, some studies in depression in adolescents, but they are quite small. And I think the main issue is that you don't know exactly the effects. The brain is still maturing, and you're going to administer magnetic pulses to the brain. So there is a lot of caution with that. But I think it might be a very nice, very interesting avenue for the future. But there is nothing really that strong on that area. But there's nothing to say that it wouldn't be helpful, for example, for particularly for depression. We need more studies.
It's a great presentation. You said that this feels like a woodpecker. So when you're doing sham control studies, can you ascertain that it's really sham? Like, can the patients really?
Well, that's important. I mean, I had a slide that I deleted, but I mean, I'm glad that you mentioned that. So I think Dr. Lozano's question is, when you want to compare the active treatment with some sort of placebo, you need to make them look exactly the same, but not have the clinical effect. So, for example, with medications, you have a placebo pill that looks exactly the same, smells the same, might even taste the same, but doesn't have the active ingredients. So with TMS, this has been a major issue from the start, because TMS produces, you have a sensation, you feel a knock in the head, you feel a muscle contraction. So if someone has tried TMS before, or has seen a video, and you give them the first generation sham coils, you'll hear a click, tick, 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 but you won't feel anything. So it's kind of like more or less easy to find out, okay, this is not the active one, because when someone is receiving, you feel the knock and you feel the muscle contraction. So so the initial approaches that have been used were the first ones were to place the coil. Instead of placing the coil like this, they would put the coil like this or like this. So the idea was that most of the magnetic field would get away from the head. But again, the sensation in the head is not as significant as when you place it like this. The second generation, they have done coils that look exactly the same as the active ones, and they do the click, but they have a shield, so there is no sensation. You just have the click, so you have the auditory stimulation, the stimuli, but you don't have the sensation. Nowadays, a third generation is to use, they put some electrodes in the head that mimic some sort of like contraction. Doesn't give really the click, but you feel something behind the coil. But I think the bottom line is that we did also, I didn't really add here, but we did also a meta-analysis comparing the patient's guesses when they tried each one of them. So after patients try the treatment, you ask them, did you receive active treatment or did you receive sham treatment? And they have to guess. And what we have shown is that there is no difference between patients who received active and sham, and not even when you look at the more modern approaches versus the old approach of just turning the coil in the head. So apparently, people seem to be blind to what they received, even though physically they are different from each other, the active versus sham. But for some interesting reason, patients are not really good at guessing what they received. Maybe nowadays, you have to think that the first generation of coils, the sham coils, were used in the beginning, so less people were aware of the treatment. We didn't have YouTube, so maybe nowadays it's going to be a bit more difficult to convince patients of that. But the newest form, the one that combines the sham inactive coil, but that makes the noise with the electrodes, might be a better way of blinding studies. But it seems to be okay. It doesn't seem to be a big issue.
The last question.
Okay.
I just wanted to know if TMS would be used on a patient with a dual diagnosis like OCD or schizophrenia.
There are studies showing that, for example, I didn't have the time to talk about it, but rTMS is a very promising treatment for a number of other psychiatric conditions. For example, in schizophrenia, for resistant auditory hallucinations, for negative symptoms in schizophrenia, there are at this point probably over 10 or 12 important trials showing that it has an effect, that it has a beneficial effect for these two conditions that I mentioned. For OCD, we have recently published another meta-analysis on OCD, rTMS for OCD, showing also some very promising results in patients who were resistant at baseline to medications and psychotherapy. We have also something that is in press about RTMS for PTSD, for post-traumatic stress disorder. Very, very small studies, but with a very interesting result as well for PTSD. So yes, I mean, we can use it for patients who have comorbid illness, but you could also use it probably, you could make the case for those patients with OCD or schizophrenia who have tried the traditional approaches, medication, for example, or cognitive behavioral therapy. TMS could be an interesting alternative, but you need more studies for sure. So TMS and deep TMS are only officially approved for major depression. Even though we have lots of studies in schizophrenia, very interesting studies in schizophrenia, we have at least 10 or 12 studies in OCD, and we have, I think at this point, probably 4 or 5 studies in PTSD. So yes, it's a promising approach. And we have treated patients with comorbidities with I think, some success.
Thank you.
Thank you.
So I know there are more questions, but maybe we can do them during the break time so that we can continue with the
Perfect.
agenda. So thank you very
Thanks so
much.
much. Thank you.
I'd like to invite Dr. Werner Knott to introduce our next speaker.
Switch to computer.
So, it is my pleasure to introduce the next speaker, Dr. Sackeim, who is based at Columbia University in New York. Dr. Sackeim is a clinical psychologist, and as you can see from your handout, he has extensive research experience in the neurobiology and treatment of mood disorders, and he has received many national and international awards for his research contributions. Dr. Sackeim is currently involved in the development of new brain stimulation therapies, but today he's going to speak to us on one of the oldest forms of brain stimulation, electroconvulsive therapy. This is a topic that's especially of interest to our center, because the Royal does use ECT with relatively good success in depression. Others would argue, however, that there are still significant problems to resolve with this treatment methodology, and we're very lucky to have Dr. Sackeim come to us today to help us address the question, does ECT still have a place in mental health treatment? Dr. Sackeim?
You can also use the clicker.
I see. Or I could use these, right?
Yeah.
Great. Good morning. It's a pleasure to be here in Ottawa. I would not have chosen this title. I think there are many more interesting things to talk about with ECT as opposed to whether it still has a role. But be that as it may, that is what we are going to consider today. Why is ECT still around? As you can see, I have a number of conflicts. I'm in desperate need of psychotherapy. Most of them have to do with the brain stimulation field. I also wanted to point out that my work in ECT, I started it in 1979. That's when I was first funded for research in ECT, and really got a big start here at the University of Ottawa, which is our first publication in ECT was in the Journal of the University of Ottawa. Dr. Sawyer Foner was the one who solicited that paper. This may be a sore point for Canadians. Should ECT go the way of the BlackBerry? But I want to remind you that you have a functioning government. There would be several reasons to doubt whether ECT has a future in psychiatry. Certainly, when you tell people in the public that you're involved in ECT and you administer the treatment, many times they say they still do that. Questioning that it's seen as obsolete, and certainly to many it's barbaric. The idea of putting people to sleep with anesthesia, placing electrodes on their head, passing electricity through the brain, producing a seizure of all things, would seem to be the last thing you'd want to do to help somebody. It's certainly counterintuitive that this is a treatment that has therapeutic properties. And it was developed, its original development in psychiatry was at a time when other desperate cures were being introduced. Malaria therapy for tertiary syphilis, insulin coma, and not insulin cum, but insulin coma. and ablative psychosurgery. So it came to us from a time when we were at a time when there was tremendous therapeutic nihilism, the belief in biological psychiatry. The ECT are mental health professionals, people like Peter Bregan, psychiatrists, who essentially take the view that mental illness is a myth, that there's no biological bases to mental illness, and so obviously ECT, certainly at the time, and now DBS going a step further, representing some of the most intense biological approaches to treating mood disorders, would be antithetical to their view. There are many former ECT patients who report that this treatment has done them harm. And we'll talk a bit about the type of harm that the treatment in fact did do and can do. There are some academics, not very many, but some academics who question whether ECT is effective at all. Typically the position they take is that the evidence for efficacy may be fairly impressive, but it's all very short term. That ECT may be something like sleep deprivation. We know that we can keep people awake who are severely depressed, keep them awake for a night or so, and up to 40-50% will have a profound antidepressant response. The reason sleep deprivation is not a treatment in our field, a usable treatment, is that they all relapse. That once people go back to sleep, you can't keep people awake for the rest of their lives. And once they go back to sleep, they relapse. Is that true of ECT? Is it profoundly effective in the short run, but lacking any durability of benefit? And then behind all of this, maybe not behind it, but certainly fueling this, are organizations like the Church of Scientology. My picture hangs very prominently in their Museum of Death in Los Angeles, and my staff has had many death threats. And very serious aspects to being in this field. So we have this anti-movement, and possibly as a result of this, ECT is the most regulated treatment in medicine in the United States and also, I think, Canada. So why is it embraced worldwide? Just ironically, this week, I found an article in the Ottawa Citizen, very prominently with the title, "Groundbreaking Ottawa Course Uses Robots to Teach ECT to Psychiatrists." Now, I don't know term efficacy. Is it truly the most effective short-term antidepressant that we have? And the concern that many people have, that does its effects last? Is there really lasting benefit of the treatment? Is there an effective strategy to prevent relapse? Do we know how to essentially treat people so that they retain the benefits of the acute course of ECT? Are there long-term cognitive deficits, and can they be eliminated? One of the things that's characteristic about ECT is that until recently, for decades, the field of psychiatry denied the fact that there could be long-term cognitive deficits with ECT. And consent statements said that all the adverse effects were essentially transient. That's not true. We now have very convincing and consistent evidence to show that, for instance, memory for events in one's own life, autobiographical memory, can show impairments months after receiving ECT. But as you'll see, we also have considerable evidence that we can eliminate those cognitive deficits depending on how we perform the treatment. And then for any treatment that's going to have a future, it should have some strategy, some direction for further enhancement, future directions that will further reduce the risk-benefit ratio. And so we will look at that. In terms of short-term efficacy, there are basically 4 types of evidence. And I'll argue that the most important evidence has not really been understood, either by the field of psychiatry or by its critics. The 4 types, and the type of evidence that has been held up the most, has been the sham-controlled trial, where patients are randomized, depressed patients, to receive real ECT or anesthesia alone. And that work, just in passing, has been highly consistent, that ECT is better than anesthesia alone. It's quite clear across these studies were done in England in the 1960s, 1970s. It's unlikely that one could ever do that again for ethical reasons, that giving these severely depressed patients anesthesia alone would not be tolerated by IRBs. But the problem with this type of research is the problem that Dr. Lozano was alluding to in terms of whether there's a credible sham for RTMS. It's very different to get a short-acting barbiturate anesthesia, wake up, and to get that short-acting barbiturate anesthesia and have electricity passed through your brain and to have a seizure and wake up. And so the question is the sham control that had been used in ECT adequate? The next set of studies, and which we will concentrate on, gives, I think, much stronger evidence regarding the efficacy of this treatment. These are also blinded randomized comparisons, but what we're doing is we're randomizing patients to different types of ECT, experimental forms of the treatment, where everybody not only has anesthesia, but also has electricity and the production of a generalized seizure. And so under those grounds, can we demonstrate profound differences in efficacy? Then there are randomized and naturalistic comparisons to medication and other forms of brain stimulation. None of those are truly blinded because it's unless you give, for instance, sham ECT plus a drug, it's very hard for the providers and patients and so on not to know that they're getting a drug versus ECT. So those are scientifically less rigorous comparisons. And then we have open naturalistic case series. To share with you a bit about the development of ECT and where we're going with these comparisons of different forms of treatment. The fundamental principle that guided all thinking about ECT, sort of the essence of the treatment, held for over 50 years. And that view is that the generalized seizure provided the necessary and sufficient conditions for the antidepressant effects of the treatment. What that meant is it didn't matter how you produce a generalized seizure. You could do it electrically, you could do it magnetically now with magnetic seizure therapy, something that I had introduced years ago, or you could do it chemically. But as long as you produce a generalized seizure in the brain, you had a powerful antidepressant treatment. And that the amount of electricity you gave was irrelevant to the efficacy of the treatment because it was a generalized seizure that got you well, not the electricity. But what the electricity did was it made your cognitive side effects worse. Okay, so that was the standard view in the field, and this quote from Scandinavians is an example of that view, where the therapeutic effect depends on the generalized tonic-clonic seizure, and giving more electrical stimulation does not enhance the therapeutic effect. The organic syndrome, what they mean is the cognitive effects, is aggravated by more electricity, was their view. The problem with this was this. Even though this view guided all thinking about the mechanisms of ECT, it had dramatic implications for practice because you would think the best way of practicing ECT would be to give the least amount of electricity necessary to produce an adequate seizure. That would both produce a therapeutic effect through the generalized seizure and minimize the cognitive effect. The field of ECT never adopted that as a practice up until that point. And in fact, the way everyone was treated in ECT around the world, and today, my estimate is it's between 1 and 2 million people a year that receive ECT in this world. That's a large number of people. But the standard practice in the field was to leave the dial in one place, at the top of the machine. Everybody got the same dose of electricity, and there was no attempt to minimize it. Back in that paper that we published here at the University of Ottawa back in 1982, we proposed titrating the amount of electricity to the seizure threshold of the individual patient. And what and this has now become practice worldwide, adjusting the dose to the threshold of the patient, the minimum dose necessary to have a seizure, and then adjusting the dose afterwards. This slide shows results from a few hundred patients in terms of where their seizure threshold is, minimum amount of electricity necessary to produce a seizure. These are in millicoulombs on here. And in my experience, I've treated patients with less than 5 millicoulombs and over 3,000 millicoulombs. There is marked variability in humanity in terms of the dosage necessary for producing a seizure, electrical dosage. In standard clinical practice, it's about 50-fold range. And what that means is because the dose of electricity was at the top for everyone, many patients were getting 40, 50, 60 times the amount of electricity they needed to produce a seizure. And the cognitive consequences of that were very dramatic. This is the first study we conducted where we randomized patients to unilateral and bilateral ECT. That's electrodes bilateral on both sides over the frontotemporal areas, or unilateral with electrodes using DeLea placement parietally and frontotemporally. And in this study, what we found is that low-dose rate unilateral ECT did not work. It simply did not work. These are antidepressant, these are depression scores before ECT, after 6 treatments, and 1 week following the ECT course, keeping patients medication-free throughout. And what we had was a response rate of 70% for bilateral ECT and only 28% for unilateral ECT. So we contradicted the fundamental principle of ECT because we produced a form of ECT that, by very conservative criteria, produced adequate seizures, but did not work. Had very weak antidepressant properties. So right off the bat, we knew that the fundamental principle was wrong. But what we were also showing here, and the point here, is that by this contrast between treatments, one treatment is highly effective and another treatment is ineffective, yet all patients are getting ECT. Now, this could have been serendipity due to relatively small samples. So in this study we published in the New England Journal of Medicine back in '93, what we did was we assumed that the failure of unilateral ECT to work at all was due to the low dosage. In that first study, everybody was treated just above their seizure threshold, minimizing the dosage. In this study, we repeated those two groups to see if we could replicate the effect. And the group at the top, low-dose unilateral, again, shows extremely weak antidepressant effects, only 17% response rate in this study. And the line in white is the exact same treatment where we increased the dosage 2.5-fold, 2.5 times above seizure threshold. So now we've modulated the efficacy of the treatment by changing the setting of a dial on the machine. This tells you, obviously, that there's a primary biological impact on efficacy, that this is biologically driven. And what it also tells you is that under the same conditions, with same electrode placement, and so on, one treatment can be ineffective and another treatment much more effective. This study did not find unilateral ECT to be as effective as either of two forms of bilateral ECT. So in the next study in this series, and this was published in the archives in the year 2000, we had 3 types of unilateral ECT. 1.5 times seizure threshold, or 50% above, 2.5 times above seizure threshold, or 150 above, 6 times above seizure threshold, and bilateral ECT, a robust form of bilateral ECT at 2.5 times seizure threshold. And these are response rates. And they're divided, each group is divided into those patients who are not resistant to medications and those who are medication resistant. What you see is that medication resistant impacts on the efficacy of ECT in all groups. that the more resistant the patient, the harder time ECT has. That's, I think, generally true for almost all treatments in medicine, that patients who fail a efficacious treatment are less likely to respond to the next treatment. And this certainly impacts on our consideration of response and remission rates with ECT. But the larger point here is that 6 times threshold unilateral ECT now is equivalent in efficacy to a robust form of bilateral ECT. This is also demonstrated in another study published in the same issue of the Archives by Nicola et al., where essentially they gave a fixed high dose to everybody, but measured their seizure threshold at the beginning, and found that as dosage was higher above seizure threshold for unilateral ECT, so was the likelihood of responding to the treatment. So there is no doubt at this point in our field that this is a treatment that has profound efficacy in the short run, that its efficacy is modulated by where you put electrodes on the head and by the dose of electricity. So that we now know that generalized seizures can be reliably produced that lack efficacy, that the seizure itself is insufficient for antidepressant response, and that intercerebral current paths and current density fundamentally determine the efficacy and efficiency, the speed of response of this treatment. That means there has to be localization to the neural systems that underlie the efficacy of ECT. Now, another point to consider, I just pointed out that medication resistance impacts on the efficacy of the treatment. In a recent study we published in the Archives, this is a multi-center trial. In fact, Columbia didn't contribute patients to this study, but we supervised it. What we are looking at is remission rates to ECT as a function of whether patients receive placebo during the course of treatment, nortriptyline or venlafaxine. And what you can see, and these various numbers refer to different cutoffs for what would be considered an adequate ECT course, how many treatments. For instance, should we consider all of the patients as 319, regardless of whether they dropped out, or do we require 8 treatments at the very end for people who we consider to be non-remitters? In any case, what you see is that nortriptyline and venlafaxine improve the efficacy of the treatment, that combining ECT with drugs is better than ECT alone. This is a radical shift in our thinking about this treatment, because studies that were done again in England in the 1960s suggested that ECT combined with medications had no difference in efficacy than ECT alone. There was no reason to combine these two. But again, the populations that are coming to ECT are very, very different today than they were in the 1960s. They're far more treatment resistant. And what we see is that pharmacology can contribute to the efficacy of the treatment. But the next question concerns the durability of benefit. How long do the benefits of this treatment last? Is ECT like sleep deprivation, ephemeral in its effects, or does it have some durability? The original view also emanated from those studies in England in the 1960s, because the patients that were randomized during ECT to drug or placebo, they also randomized them to drug or placebo following ECT. And the view then that came from those trials was that if you gave nothing but placebo following ECT, 50% of patients will relapse within 6 months. 50% will remain well. If you give a drug after ECT, 20% will relapse within 6 months. So that there was a decided advantage to medication, but that overall you even had a 50% chance of remaining well if you got nothing. We did a series of naturalistic studies. In all of those trials that I showed you just earlier, we followed patients for at least a year at Columbia with bi-weekly phone calls and assessing their clinical status. And what we found is that we were getting, in extremely well-treated patients pharmacologically, 50% relapse within a year. That this seemed to contradict the work from England, which had suggested that it should be around 20%. And so we were alarmed. This is the first modern study, and now there have been several, to look at optimal treatment post-ECT. And in this study, this is a multi-center study, in which we randomized post-ECT patients who remitted to placebo alone, nortriptyline and placebo, or nortriptyline and lithium. And this is the survival curves for the 3 groups. This was published in Journal of the American Medical Association in 2001. And what we found was that virtually everybody relapses if you get placebo after ECT. It is no longer 50% stay well. It was 84% relapse rate in 6 months following the study. And this is for virtually all the patients nowadays that are coming to the brain stimulation treatments. It's quite clear that they need some form of continuation treatment, as we were discussing earlier, after the treatment. With nortriptyline alone, we reduced the relapse rate to about 60%. Still unacceptable, but better than placebo. And with nortriptyline and lithium, we reduced it to about 40%. So what we now know is that without continuation therapy, virtually everybody's going to relapse. There have been trials that have compared, for instance, nortriptyline and lithium to continuation ECT, using ECT as a method of relapse prevention. Because until recently, ECT was the only treatment we had in psychiatry that we stopped once it worked. Everything else we continued once it worked. But nortriptyline and lithium and continuation ECT have been found to be essentially equivalent. And nowadays, conservatively, the relapse rate following ECT, with the best treatment we have, is about 50% in the year following the treatment. About half of the patients who go through this, who benefit markedly, will lose it during the year following the treatment. So when we estimate long-term benefits, and this is probably the most controversial slide in this talk because I'm trying to estimate remission rates and relapse rates for various forms of treatment. ECT is not 90% remission rate. In terms of almost all the modern studies, at the most select research centers, its remission's around 65%. In the community trials, it's around 50% remission rate acutely. And as I said, the durability is about half of the patients will remain well for a period of time. Pharmacotherapy is hard to come up with estimates because there are very few studies of the type of resistant patient that comes to ECT. I was a science advisor for STAR-D, and our estimates in that trial is from stage 2 to 3, 4, probably about 20% reach remission. And critically in that study, the more resistant you were, the more likely you were to relapse following the treatment. So again, we probably have about a 50% durability effect for pharmacotherapy, even if you stay on the same drug that got you remitted. So the long-term benefit, when we do the conditional probabilities, is only 10%. If we jump to TMS, arguably, being very generous to TMS, we have about a 30% remission rate in terms of some of the naturalistic studies. The two major trials in RTMS, the trial I conducted with Mark George for the NIMH and the Neuronetics trial, found about 15% remission rates. And in both of those studies, you're much more likely to remit if you were low in medication resistance than if you were higher in medication resistance. So RTMS is probably better off earlier in the treatment course, as was suggested. And we don't have data yet, really good data, on its durability benefit. I'm working with Neuronetics right now to write up their results on the durability benefit for RTMS, and it looks like it's quite promising, actually. Going up, VNS. VNS was a disappointment in its acute effects, but in its long-term durability, it was excellent, sort of unappreciated, so that its cumulative probability of the long-term benefit may be superior to pharmacotherapy. DBS, again, we don't have a large database in the world, and 50% may be low for its short-term remission effects, but it appears to have remarkable durability benefit. The two treatments, VNS and DBS, are characterized by the fact that you continue the treatment once patients respond. You're continuously being stimulated 24/7, and that may contribute to their durability. Now, so I think it's quite clear that ECT is probably our most profound antidepressant, and it has overall, compared to the other treatments, excellent excellent short-term efficacy and decent durability benefit. There are other points to consider with regard to efficacy. the antidepressant effects that you see underestimate the impact on quality of life. Vaughn McCall, a colleague of mine, using data from a number of these studies, have shown that ECT samples are characterized by marked impairment of quality of life before starting the treatment. And impairment of quality of life, difficulty functioning, is probably one of the most important factors influencing the referral to ECT. In our most recent study, we found that if you follow patients who remitted with ECT and stayed remitted for 6 months, the quality of life estimates in those individuals is no different than matched normal controls. That they remit and they have a profound improvement in their quality of life. So that's one other thing to consider. And then, likewise, the diagnostic indications for ECT are much broader than they are than just major depression. And they include acute mania, schizophrenia, catatonia, in some special cases, Parkinson's disease. My group introduced its use in breaking up status epilepticus. And very recently, there's been considerable interest in use for injurious behavior in autism. These are kids that are gouging their eyes out, who are attacking their siblings, who are showing considerable symptomatic benefit from receiving ECT. So when you think about the spectrum of action of this treatment, it's much, much broader than depression. Now, quickly to move on, are there long-term cognitive deficits and can they be eliminated? Some general principles regarding the cognitive effects of ECT. What you see in terms of the nature and severity of these cognitive effects is very much a function of when you look, because there's rapid improvement from the cognitive effects that you see immediately following the end of the seizure. At the end of the seizure, the patient may be disoriented, showing soft neurological signs, showing some hard neurological signs, but they disappear rapidly. And so when you study them is quite important. The side effects can be divided into the acute right after the treatment, short-term, week or two following the treatment course, and long-term. There are wide individual differences. So consent procedures have to account for the fact that not everybody is the same, and there are some people who are going to have more severe reactions to this treatment than others. These cognitive side effects are generally stereotyped. Most domains of cognition are unchanged or improved following the ECT course. Even in the short term, attention will improve, reaction time measures will improve, on and on. There's no impact on intelligence, even in the short term. How ECT is conducted, the technical aspects of the treatment, has a profound impact on the nature, severity, and persistence of cognitive side effects. To give you an example, in the days when we were using sine wave electrical stimulation and bilateral placement, the average time it took patients to know their name, where they were, and so on after a treatment was 8 hours. It's now down to 4 minutes, 4 to 5 minutes. That's a massive change in the cognitive, and it's a function of technique only. What the psychiatrists have tremendous power with this treatment. The fear of cognitive side effects is undoubtedly one of the factors limiting its use. We don't have time to review all the cognitive side effects. The most important is retrograde amnesia, typically for information about oneself. That is where we have the best evidence for persistence of deficit. That's what patients complain about the most. And basically, the amnesia that you see is densest for events that occur during the ECT course and the weeks and months just before the course. Some patients will report a very dense retrograde amnesia that extends back years. They may not remember having closed a bank account or attending a funeral of a loved one, or a vacation trip that was spectacular that they took, or the birth of a child. And these persistent effects may last a lifetime in terms of loss of memory. Now I'm going to illustrate these long-term effects, this retrograde amnesia, and how they can be ameliorated by just pointing to one study, a study we conducted focusing on the width of the pulse used in ECT. You just heard that in RTMS they use a pulse that's typically about 0.25 or 0.3 of a millisecond in duration. Likewise in DBS, it's a very short pulse, much less than a millisecond duration that is used. In ECT, traditionally we had started out with the sine wave stimulus, which is duration in the United States is 8.33 milliseconds. far wider than anything used in the rest of brain stimulation. When ECT moved away from sine wave to brief pulses, the width of the pulse was 1 to 2 milliseconds in width. The typical chronaxi of a neuron, what a neuron wants to see to be depolarized, is a pulse with a width of about 0.25 to 0.3 of a millisecond, or even below 0.1 of a millisecond. So ECT had been using until recently pulses that were much, much wider than that necessary to produce a seizure, and were stimulating the brain unnecessarily. So to show you an example of one of these studies, this was published in Brain Stimulation in 2008, we randomized patients to a pulse width of 0.3 of a millisecond or 1.5 of a millisecond. And this is the titration schedule. I tell you how we find the seizure threshold for the person. So under anesthesia, we stimulate number 1 with 20 hertz, 20 pulses, actually 20 pulse pairs, it's bidirectional per second, with a train duration of half of a second. That produces, with a 0.3 millisecond pulse width, a charge of 4.8 millicoulombs. Or if we use the wide pulse width, a charge of 24 millicoulombs. If the patient doesn't have a seizure at that setting, we then re-stimulate after a brief delay at the next level or the next level, and so on. In this study, we randomized patients to unilateral ECT at 6 times threshold or bilateral ECT at 2.5 times threshold with the narrow pulse width or the wide pulse width. What you see here is the seizure thresholds of the 100 patients in the study. A mammoth effect of pulse width on seizure threshold, larger than the effect of electrode placement. Seizure thresholds higher with bilateral than unilateral ECT. That's been replicated many, many times. But it's also much, much lower, about, in this study, 3 to 4 times lower with the ultra-brief pulse than with the standard brief pulse. So we could give much less electricity to the brain using a narrow pulse. And that's just following the physiology where the chronaxi, the ultimate pulse width to produce depolarization, is much narrower than had been used in ECT. 2 or 3 days following the ECT course, these are scores of normal controls and the 4 ECT groups on a measure in which we ask several hundred questions about events in the person's life. Where were you last New Year's Eve? What were you wearing? Who were you with? What was good about it? What was bad about it? What is the address of your job before last? I can go on and on, but you can see these are not necessarily that easy questions to answer. And we collect hundreds of these facts about a person's life and then re-ask the same questions after ECT and 2 and 6 months later. And what you see in this slide is these are in standardized units of the autobiographical memory interview. And what we see here is that those patients who received the ultra-brief unilateral treatment did not differ from normal controls, but each other group differs from each other. So we're a full standard deviation away with the bilateral brief standard pulse treatment. So the treatment groups differed markedly in this retrograde amnesia following the end of ECT, and the ones that received ultra-brief treatment with unilateral did not differ from controls. Now these are removing the effects you see in controls from each of the groups. This is just replaying these data on the right, the post-randomization course. And then patients who did not respond to their randomized form of ECT got a second course of ECT with high-dose bilateral with a standard brief pulse. That's that dark filled-in group, and you can see their scores are really quite poor right after that crossover. Then we follow the patients at 2 months and at 6 months. And basically what you see is that the patients who received ultra-brief treatment, either unilateral or bilateral, had no deficits, no retrograde amnesia that we could pick up. That they were right at the origin, whereas those who received the standard brief pulse treatment had marked deficits that we could see 6 months later. To give you a flavor for how this works out in standard practice in the community, this is another study we published in Neuropsychopharmacology, and where we followed patients that were treated at 7 hospitals in the New York City area. And on your right, what you see is scores on that same type of scale as a function of hospital, immediately following ECT and 6 months later. 6 months after receiving ECT, the amount of amnesia you had from information in your own life was a function of what hospital you went to. And it really wasn't the hospital that mattered. It was how they treated the patient, whether they used a standard brief pulse, whether it was bilateral, how many treatments. We could demonstrate that the hospital differences disappeared when you looked at ECT technique. So yes, indeed, ECT can have persistent long-term effects on things like retrograde amnesia for information in one's own life. But it's also the case that those effects can be markedly reduced by optimizing practice. So the conclusions about adverse effects: severity and persistent, strongly related to how ECT is performed. Objective long-term deficits have been demonstrated. And by the way, on this measure of retrograde amnesia, it's the only measure we've had in the history of ECT to correlate with patients' own evaluations of how much memory effects they've had from the treatment. So patients who say this treatment has affected me adversely in terms of my memory, we see that in this measure of retrograde amnesia. The deficit can be markedly reduced, if not ameliorated, by optimizing parameters. And with optimal technique, obviously, the risk-benefit is strong. Now, I'll conclude by just giving you a taste of where we can go in the future. Is this treatment stalled? Is it just archaic? Or is there a direction for future development? There are many possibilities. We haven't finished with optimizing the electrical parameters of the treatment, which have had a profound impact in our understanding of both efficacy and side effects. But where I think the real future lies is going to be in spatial targeting, the road to focalization. It is now established that the cognitive effects and the efficacy of the treatment are contingent on where the current goes in the brain and the density of current in that path. Thus, there has to be localization in neural systems that subserve efficacy and adverse effects. Furthermore, over the 80 years of this treatment, it has been consistently the case that the efficacy of the treatment and the severity of the cognitive effects are independent. That's true both behaviorally when you correlate the amnesia with the antidepressant response, and it's also true in terms of imaging results, where you look at what are the regions that seem to be subserving efficacy and what are the regions that are subserving the cognitive effects. So more focal forms of ECT are entirely feasible where we target the regions that are responsible for its efficacy. Two types are magnetic seizure therapy, using essentially the same technology as you just heard about, but now concentrating it in a much more powerful form, going up to 100 hertz, for instance, in MST devices, producing a electrical current in the brain through a magnetic pulse that can be much more focal and targeted because the skull and the scalp are transparent to the magnetic field. That's one way. There are real limitations of that approach, magnetic seizure therapy, and they have to do with dosimetry and the fact that it tends to be very superficial. You can't reach deep structures and so on. I think a more likely frontal activity to the antidepressant effects and temporal lobe function to its amnestic properties. And our understanding of how ECT works emphasizes very much where the seizure starts as opposed to where it spreads to. Despite the fact that a generalized seizure is produced, the inhibition that shuts the seizure down, much like in focal seizure disorders, is targeted at the site of seizure initiation, not propagation. Now, to give you just some examples, this is long ago, still the largest sample in ECT to ever go through repeat imaging. Using the xenon inhalation method, we quantified, fully quantified cerebral blood flow in over 60 ECT patients, divided them into whether they responded or not to the treatment. And what we saw is that reductions in blood flow in prefrontal regions was strongly related to clinical outcome with this treatment. We saw the same thing with glucose metabolism in PET, so that you can see these deep areas. This was patients through bilateral ECT who had bilateral reductions in temporal areas and in frontal areas. The frontal effects covariated with the efficacy of the treatment, the temporal with the amnestic effects. We saw it in the EEG. These are topographic patterns in the EEG in terms of delta, slow wave activity. ECT induces a massive increase in slow wave activity in the EEG. And the first pattern is a frontal predominance of that delta. And you can see second pattern is a temporal predominance, and the third is a laterality pattern. Well, these are scores on that first pattern in responders and non-responders to the treatment. So again, producing this inhibition and prefrontal functioning seems to be related to clinical outcome with ECT. Given this and many other suggestions, we developed a technique called FEAST that I just mentioned, and have just published on this technique in depressed patients. We preceded this work with work in primates. And in FEAST, what we're doing is using a unidirectional current, with current flow only going in one direction, as opposed to the bidirectional that's typically used in ECT, with a small anterior electrode and much larger, essentially, cathode, which we try to place just anterior to the motor strip. We're hoping ultimately with FEAST to be able to provoke seizure activity from focal prefrontal areas without a convulsion, inhibiting the spread of the seizure to motor strip, so that we can ultimately, if this technique develops, there may not be a need for anesthesia ultimately. This type of view rests partly on the idea that there may be a final common pathway for treatment of mood disorders. These are PET data quantifying blood flow on the left, on the left top, in about 30 ECT patients. This is 20 minutes following a seizure. And all the areas in red that you see are areas of blood flow reductions. Massive reductions in the post-ictal state, massively through the frontal cortex, but also parietally. This is a mixture of unilateral and bilateral patients. These are data on patients treated with sertraline for depression, where we found a 80% correlation between change in a particular network, again, of prefrontal regions and antidepressant effects. And on the right, on the bottom, you see essentially old data from Mark George using SPECT, suggesting also a prefrontal aggregate. These are data from a monkey in some of our very early FEAST work, where we were trying to provoke seizure from the right hemisphere, and what you're seeing is EEG during the seizure, where the right lead from the right hemisphere is showing quite pronounced seizure activity, highly reduced on the left side. That's probably due to conduction. There's likely to be no seizure activity there. We got in monkeys Jacksonian seizures for the first time. I've never in a human, in doing ECT, seen a seizure that just started in one part of the body and then spread. And that's what we got with FEAST. So we were pretty convinced from the animal work that we could provoke focal seizure activity with this new method. These are data that were just sent for publication, where SPECT was used to try and identify the site of seizure onset with FEAST. And again, what you're seeing at the top is a very localized site of onset in the right hemisphere with right-sided FEAST administration. And this is in the immediate post-ictal state, again, where you're getting a much more reduced but marked decrease compared to, for instance, our work with standard ECT and PET. So to conclude with the last view of the future, these are data from NeuroPace and their type of responsive stimulation. This is a brain stimulation technology where you read the EEG of the patient. When the patient has a seizure that's being detected by the EEG that's implanted on the cortex, you have grids that are implanted on the cortex, you stimulate electrically. And when you stimulate electrically, you can shut the seizure off. There are now a host of studies that show that electrical stimulation can be used to turn off seizures in men and in animals. But the point here is we can use responsive stimulation ultimately with techniques like FEAST or standard ECT, where we see in the EEG the emergence of the seizure, and we shape either the spatial extent or the electrical parameters of the stimulus based on the emergent seizure technology. And that's where I think ultimately we will end up. So does ECT have a role? Short-term efficacy is profound, and the majority of patients remit. Relapse is the most important issue limiting its use today. And ECT really is the field that brought into psychiatry and in depression work the importance of durability of benefit. It was a concern about relapse following ECT that has led to this explosion of interest in durability. Nonetheless, overall long-term efficacy is superior to almost all other alternatives and markedly better than pharmacotherapy. Retrograde amnesia is the most persistent adverse effect and can be reliably quantified. Optimal treatment techniques markedly reduce this amnesia, and the great majority of patients report that memory loss is a small price to pay for the relief that they get. ECT demonstrates efficacy in a wide assortment of psychiatric neurologic conditions that can be life-saving, and there are viable and exciting strategies for further risk-benefit improvement. Thank you.
What is the role of standard bilateral ECT nowadays? When would you give it? Where would you put it in an algorithm using ECT?
Algorithms regarding ECT, optimal ECT technique are I'm sure you'll get different answers from a lot of different experts. I prefer to see people start with right unilateral ultra brief as their standard treatment. And then if there is time and opportunity and the patient isn't medically compromised, isn't profoundly suicidal, I would prefer to go to a standard brief pulse with unilateral before switching to bilateral.
I was going to ask that same question, but now I'll ask a different one. What would you say is the role of bilateral ultra-brief stimulation? I noticed in the work about cognitive impairment it's better than unilateral brief, but I know the original data didn't support its efficacy. So yeah, I'm just curious about your role, your opinion
right.
on bilateral ultra-brief.
One of the things that considerable modeling work and conceptual work has shown is that when you narrow the pulse, you're not just changing the electrical dosage patient's receiving, but you're changing the geometry of the area of the brain that is being triggered in a seizure. You're reducing the volume of tissue involved in that. We found that at 6 times threshold, right unilateral ECT, ultra brief, was very effective, but 2.5 times threshold bilateral ECT lost efficacy. I didn't show you the efficacy data here, but that was another one of those studies that found that depending on how you do the treatment, you get different efficacy results for subgroups. I'm convinced, absolutely, that if we increase the dosage of bilateral ultra brief, it would be more effective, that it was a dosage issue. But because it had inferior side effects, it had more side effects than ultra brief right unilateral, we felt no reason to, we abandoned that treatment. We didn't develop it. That if you're going to give ultra brief, I would just give unilateral.
Okay, thank you.
Very interesting presentation. I was wondering about your thoughts on the relationship between anesthesia and the ECT, particularly in the context of the new treatments with ketamine that are showing quite beneficial effects, not at anesthetic dose, but sub-anesthetic dose. But I'm just wondering about the relationship between the two, whether there's a potentiating effect.
A couple of thoughts. First, until recent years, all the anesthesia used in the ECT was short-acting barbiturate anesthesia. Unappreciated is the fact that in the sham-controlled trials, where patients just got the anesthesia alone, there's a pretty decent relationship between the dose of anesthetic and the antidepressant response in the sham patients. That even though the sham response was much lower, I think the anesthesia is an active contributor to the antidepressant effects of the treatment. And I think that's largely through GABAergic mechanisms. Likewise, I think that the shutdown, the inhibition that we see following the seizure is through GABAergic mechanisms. The use of ketamine, either alone or as an adjunct to anesthetic, is a hot issue in ECT. I think it likely has more potential with regard to cognitive side effects than it does to efficacy. This is just speculation. But we know that sub-anesthetic doses of ketamine are profoundly antidepressant. There's a lot of interest in the field. The fact that within a day you can get an antidepressant response with subanesthetic ketamine. But so far, I'm not impressed with the efficacy seen in ECT, and it doesn't seem to improve much. You know, if you use ketamine in full anesthetic dose compared to methotrexate or propofol, there's very little difference in efficacy. And if you give a subanesthetic dose as a supplement to your anesthetic, I don't think there's really convincing evidence that it helps. I think that glutamatergic blockade, which is presumably what we're getting with ketamine, may help with the cognitive side effects, because I think it's the excitotoxicity that you get from this massive glutamatergic rush that may be contributing to a lot of the cognitive side effects. So that's where I think there may be a future there.
Sorry, can I just ask one more question? In Canada, there's a BC group who have looked at bifrontal ECT, so it's a relatively common practice. I'm just curious if you have an opinion about the use of bifrontal electroplasmids.
Yeah, I think the use of bifrontal was motivated largely by our view that it's these very anterior frontal systems that may be critical to the antidepressant effect, and whereas this medial temporal systems that seem to be mediating the amnestic effect. So the thought was if we put the electrodes here and here as opposed to bilateral here and here, we could get the efficacy and reduce the side effects. That was the theory. I think the problem with it, and there is a problem, is that the frontal bone here is the thickest part of the skull, and there's a good reason why Triletti and Bini chose this area first for bilateral ECT back in 1938, which is that it's extremely and you can get current in the brain very easily. So I think we're largely getting shunting and entrance in the same places as we get with bilateral ECT when we do. That's why I don't think there's been very clear data regarding does it really have a cognitive advantage.
Thank you very much.
Welcome.
So we're going to take a break.
So I think we're having a break now, and we'll be returning in 20 minutes for the next talk. Thank you.
All right, we're ready to start the next session. So welcome back, everybody. I hope you're enjoying the series. I think it's personally find it quite exciting. Our next speaker, it's an honor and privilege to present to you our next speaker, who is Dr. Andrea Lozano, who originally is from Ottawa, and he's a professor and chairman of neurosurgery at the University of Toronto, and holds both an R.R. Tasker Chair in functional neuroanatomy, and he also holds a Tier 1 Canada Research Chair in neuroscience. For those that don't know, Canada Research Chairs are the highest award a government of Canada can bestow upon a scientist. So it's quite an honor to have that. He's best known for his work in deep brain stimulation and the application of deep brain stimulation in several conditions. He's going to be talking to us about mental health in particular, but his work in depression is very, very exciting. His team has mapped out the cortical and subcortical structures in human brain and have pioneered application of the deep brain stimulation for various disorders, including Parkinson's disease, for example, depression, dystonia, anorexia, Huntington's disease, and recently there was a trial going on for Alzheimer's disease. These are all really very important developments. And for those that may be following some of the scientific politics in the United States, you might know that President Obama has recently initiated a brain initiative in the United States, the target of which being unraveling the brain circuits that may underlie several of these conditions, and one of the ideas being that if we could identify the circuits that are responsible in the brain for a particular symptom or a syndrome or an illness, then we might be better able to target treatments. So the work a very important work that's being done by Dr. Andrea Lozano and his group is not only in therapeutic application of technology to patients today, but also in terms of unraveling some of the brain circuits that may actually be controlling brain function and help us better understand the overall functioning of the brain, so that in the future we can be much more targeted in terms of treating conditions, particularly when they happen to have a comorbid conditions. As you know, more often than not, you very rarely have a single clean condition. You have several conditions simultaneously. So the more we know about how brain functions and the circuits link, the more we'll be able to develop more strategic treatments. Dr. Lozano is a very prolific scientist. He has published well over 400 publications, which is really extremely high. We drool at a publication record like that, those that are in science. He's a member of the Scientific Advisory Board for the Michael J. Fox Foundation, among other things. He has received numerous awards, including Margulies National Brain Award, Oliver Corona Medical Award, the Pioneer in Medical Award. He's been elected the Fellow for the Royal Society of Canada, the Canadian Academy of Health Sciences, and has received the Order of Spain. So these are just an inkling of the all kinds of awards that he has gotten. But certainly he's a giant in Canada and a pioneer in a very new, exciting realm of treatments through brain stimulation. So without further ado, Andreas.
Well, thank you very much, Dr. Morales. It's a real pleasure to be here. As you've heard, I went to medical school in Ottawa, and in fact, I did my psychiatry rotations at this hospital. So it's great to come back to where I had my first exposure to psychiatry. And as you've heard, I'm not a psychiatrist, I'm a neurosurgeon. And so I do operations on the brain. And what I'll be telling you about is the possibility to go really just about anywhere in the brain and to change the activity of circuits in the brain. So we can adjust the activity of a circuit in the brain, either turn it up or turn it down using electrical stimulation with implanted electrodes. And this is called deep brain stimulation. And it looks something like this, where you put the electrodes anywhere you like in the brain, and then there's a cable that runs down underneath the skin all the way to a pacemaker. And then with a remote control, very much like your television remote control, you can adjust the volume or change the channel so that you can deliver current to these various contacts in the brain. So this is a technique that has been used in a widespread fashion, mostly for Parkinson's disease, and indeed 100,000 patients in the world have received deep brain stimulation for Parkinson's disease. So the issue is with the success of and the experience of using this technique for Parkinson's disease, could it be applied to not a circuit that involves movement like in Parkinson's disease, but could it also be applied to circuits that involve mood? And this is what I'll be telling you about today is, can we apply this same technique to treat patients with other disorders? And just this is an area of neuroscience that is just exploding. And just to give you a taste of this, we recently compiled the number of active studies using deep brain stimulation that are registered at the NIH government site. And so we published this a few months ago. And there are currently 93 trials that are published. And this is now trials of using deep brain stimulation to treat various disorders. So just to give you a flavor of the kind of disorders that are being investigated as potential benefits with DBS, so there's Parkinson's disease and Parkinson's disease plus, 7 trials of major depression, 6 of obsessive compulsive disorder, 5 of Alzheimer's, 4 dystonia, 3 epilepsy, 2 drug addiction, treating drug addiction with DBS, 2 cluster headaches, 2 essential tremor, 1 anorexia nervosa, that's mine, I'll tell you about that one, 1 bipolar, that's also mine, I'll tell you about that, chronic pain, diffuse Lewy body disease, Huntington's, Tourette's, traumatic brain injury. It might be possible to regulate an appetite, so if you eat too much, you might be able to turn down your appetite with DBS, right? So it's obesity, tremor, MS tremor, multiple sclerosis, urinary function, movement disorder. So this is just to give you an idea of the scope of this, and basically the message here is that no circuit in the brain is safe because we can really go after any of these circuits in the brain to either turn them up or down to see if that will help our patients, right? So as I told you, I'm a neurosurgeon, and when we first had the idea of treating depression, the first thing I did was let's go back and find out what is depression. So I thought that was important because I hadn't heard about depression, for like 15 or 20 years. So let's figure out what depression is. So I thought it would be important to do that. It Turns out that depression is a pretty complicated thing that is multifaceted and multi-symptomatic. So it has, for example, a mood component, so your mood is depressed. You have a marked diminished interest, so that's called anhedonia. You're not interested in things. Things don't bring you pleasure. So that's anhedonia. Significant weight loss or weight gain. So you're already seeing that very different areas of the brain are involved in regulating these things. Insomnia, sleep disturbance. So another area of the brain here too. Fatigue or loss of energy, other areas of the brain. Feeling of worthlessness, that the world would be better off if I was dead. Then diminished ability to think, so executive function, so frontal lobe function. Recurrent thoughts of death. So I was impressed by the wide constellation of symptoms. And I was wondering, what are the neuroanatomical substrates? What are the areas of the brain that are responsible for generating this huge number of symptoms? And we can't pin this down to one area. We have to postulate that there are multiple areas that are involved. And any treatment that is successful must engage all these various areas. So maybe we're talking about a network of interconnected sites. And is there a way of getting into this network? Is there a way of influencing this network that has various channels, has a cognitive channel, affective channel, behavioral and somatic and vegetative channel? So I was impressed by how widespread the disturbance in the brain and how many areas of the brain must be involved and engaged in producing depressive symptomatology. So as a neurosurgeon, what can we do to tackle this behemoth? In addition, as you've heard, we have treatments that are effective, but about 30% of people fail. And as you've heard, the estimates are somewhere in the order of 10 to 20% of patients that fail everything, that fail multiple drugs, that fail cognitive behavioral therapy, even that fail ECT. And these patients that fail these conventional treatments are designated as having treatment-resistant depression. So I'm interested in these patients that have really tried just about everything else and are still disabled. These patients with treatment-resistant depression. And this illness not only affects your quality of life, but this illness is a killer too, because if you have this type of severe problem, then it also kills you, because a good number of these patients, 15% or so, will commit suicide. So it not only affects your quality of life, it also affects the length of your life. So being a neurosurgeon, what can we do about this? So I teamed up with my colleague Helen Mayberg. And Helen is interested in studying what areas of the brain are involved in causing depression. And let me tell you about two experiments that she did. The first experiment will be on the right. So the first experiment is called a mood induction test. So what we do is we take normal people, we put them in the PET scan, and we make them as sad as possible. And when they are at the peak of their sadness, we take a picture of their brain to see what areas of the brain light up. So this is called a mood induction test. This is typically done by getting them to write down a story about the last time they saw their mother before she died, for example. So they read the story, they're good and sad, and as they're sad, we take a snapshot of the blood flow in their brain, and we see what areas of the brain become activated during sadness. And when you do that, the areas in red are the areas that increase their blood flow, and sure enough, this area of the brain called area 25 lights up. There's a huge increase in blood flow, which is a surrogate for the neurons in this area are more active. The neurons are starting to fire during sadness. So we think that this is the sadness area of the brain, or one of the sadness areas of the brain. Let's now move to this side of the panel, and here it's a different experiment. Here you take patients who have depression and you treat them with antidepressant drugs and they improve. And you ask the question, what is different from the time they were depressed to the time that they are now better? What has changed in the brain? What has changed? And what has changed is that you see a decrease in the activity of area 25, which is associated with an amelioration of their depression. So here you have decreasing the activity of area 25 improves depression, and increasing the activity of area 25 is associated with sadness. So from experience of this type, we postulated that perhaps area 25 would be a good target to go after patients with depression, with the idea of perhaps we should try to turn it down in patients with depression to see what would happen. There were also other lines of evidence. Remember how I told you that their depression is multisymptomatic. What is area 25 connected to? What is area 25 in a position to influence? You can inject tracers, neuroanatomic tracers, into area 25 in monkeys, and you can see the direct connections of area 25 to other areas of the brain. And this was done by Unger and Price. And in fact, if you put an injection in area 25, you see that there are direct projections to the hypothalamus. And as you know, these areas of the hypothalamus are involved in sleep, appetite, and cortisol regulation. These are all disturbed in depression. So area 25 is in direct control of these areas of the hypothalamus because it's monosynaptically connected. Also, area 25 projects to the brainstem, to the periaqueductal area. It's an area positioned to influence serotonin, norepinephrine, and opiates. These are also disturbed. Sleep, pain are also disturbed in depression. Area 25 projects directly to the amygdala. As you know, the amygdala is involved in stress responses, circadian regulation, and emotional reactivity. And also, area 25 projects to the shell of the nucleus accumbens. So the nucleus accumbens is involved in reward. Lack of reward or lack of seeking pleasure is a problem in depression, anhedonia. So perhaps area 25 is involved in the anhedonia that is seen in depression. So the message here is that by intervening at the level of in area 25, one has the possibility of influencing many of the major vegetative aspects of depression. So by intervening in this one area, we might have an effect that goes beyond its borders to its primary projections. So we then had a clinical rationale with a large number of patients with ongoing disability despite current available treatments. In the order of 10 to 20% of patients with depression do not respond to available treatments. We had a physiologic rationale with a target, with a role in acute, for example, acute sadness, this area lights up, and chronic mood regulation. As you improve your depression, this area goes down. And we have an anatomical rationale where area 25 is positioned to impact the activity of both local and remote regions throughout the brain that are implicated in depression. So with this background and rationale, we went ahead and we asked for permission to do the first trial in human beings to implant electrodes in this area of the brain. We chose patients that were between 20 and 70. They had to have been ill with the current episode lasting at least 12 months. They had to have failed at least 4 different treatments. They had to have had adequate doses and duration of these treatments. They also had to fail or refuse ECT. So it turns out that 85 or 90% of our patients have had ECT, but they have depression that is severe despite ECT, despite psychiatric therapy, despite drugs. They have a Hamilton Depression Score. This is an index of the severity of depression greater than 20. They have a global assessment of function less than 50, which means that they're impaired. They're able to give informed consent. We excluded patients that had other psychiatric disorders, so we didn't want that interference in them. And also, if patients were actively suicidal, we did not include them in the trial because we wanted them to be around for the duration of the trial. So this is our team, psychiatrists, Dr. Kennedy, Dr. Jacoby, Dr. Voon, Helen Mayberg did the imaging, neuropsychology, neurophysiology, and neurosurgery. So this is a team effort. So the way this procedure works is we put on a frame like this. We drill 2 holes. We freeze the skin. It's like a little bit like going to the dentist. Freeze the skin, make holes in the skull, put these electrodes in like that, and then we hook them up to a battery like that, and then we turn on the battery. Now, as we do these operations, we go through the brain, and we go in a trajectory that looks something like this. And this is the area here. So this is called the subgenual cingulate gyrus. So this is the genu of the corpus callosum, and this is the cingulate gyrus below the genu. That's why it's called subgenual. And you'll notice that there's some gray matter here. There are neurons in this gyrus, and we're able to record from these neurons. So as we go in, we can go in with a small electrode, a microelectrode, and we can record from the neurons in this area of the brain. And we can ask, for the first time, no one's ever gone to this area of the brain before, so we can ask, what do the neurons there do? So it gives us a great opportunity to map out and to discover, what the neurons do. It's just sort of like Christopher Columbus arriving, on Santo Domingo, and there's people there, and you can ask them, what are you doing here? So the same kind of thing where we can go there for the first time to this area of the brain and ask these neurons what they're doing. And we thought that they might be involved in emotional processing. So what we're doing is the patients are awake, and we have an electrode here. We're recording from a single neuron, and then we are showing the patients various pictures that have an emotional context or content. And then we're asking, what do the neurons think of this? Is there anything that drives these neurons? Are they interested in these things? So it looks something like this, where the patient's awake, and then we're recording from a single neuron, and we might show them a picture like this. So this is a disturbing picture, violent picture. This is from the IAPS, for example. So here's a sad picture. And all the while, we're seeing whether the neuron flinches, whether it increases or decreases its activity in response to these pictures, right? And then we might wait another 2 seconds, and then we might show a neutral picture like this one, or we might show a happy picture, or we might show an exhilarating or exciting thing. And we want to know, like, what do these neurons, what makes them tick? What are they excited about? And it looks something like this. So these neurons typically fire 6 or so times per second. And then this is when there are no pictures being shown, and then you might show them a picture like this, and then all of a sudden the neuron starts to perk up and starts to fire higher, and this tells us that this neuron is involved in processing this emotion. And then we turn off the picture, and then the neuron will go back to the way it was before. So we do this, and we show these neurons hundreds of pictures, and we align all these responses, and then we get something like this. So here's an example of showing these. So we showed these neurons, 86 neurons, these various pictures, and what the neurons in this area of the brain are interested in are things that are disturbing and things that are sad. They are preferentially interested in this. They change their activity in response to disturbing things and sad things. They don't care about neutral, happy, or exhilarating too much at all. So we think this is the area of the brain that's involved in processing disturbing and sad things. And we are tempted to postulate that the reason that people have depression is that the set point of these neurons, that their activity is overactive, that they're overactive. The reason that you're depressed might be that these neurons, instead of firing at a normal rate, they're just on all the time. And this excessive activity might contribute to the disturbance, not only in this area, but also to all the downstream areas to which Area 25 is connected. So that's the hypothesis, is that the neurons here, either because you were born this way or because of events in your environment, the neurons here have started to be on very much like as if the thermostat in your house is set to 100 degrees instead of 68. All right, so that's the hypothesis. So if that's the hypothesis, then we're going to go in with an electrode to see if we can turn the thermostat down back to a more normal level, right? So we put the electrodes here. So we've done the recordings. We now put the electrodes, and this is called the subgenual singular jar. So these are MRIs of 4 patients with the electrodes in place, like that. And then we turn on the electrodes, and we see what happens. And we have 2 questions. Number 1, does this do anything to depression? And number 2, what happens to the activity of this area when we turn on the electrodes? Okay. So this is what happens as soon as you turn on the electrodes. The patients are, awake. They're in the operating room or outside, and what they see is as soon as they turn them on. This is seen in about roughly 75% of patients. A sense of intense calm, quiet, relief, lighter, dissipation of visceral symptoms. Someone may say, "I feel like a weight is lifting, a cloud is clearing." This happens within a few seconds. And this is all to do with self-awareness, with interoceptive awareness, awareness of the self. This is followed 10 or 15 seconds later by the patients start becoming more active. They start looking around. They start seeking things. They start speaking. They start moving. They have an increased sense of connectedness, of social engagement. One of the patients, for example, said the room colors are changing. It used to be black and white. Now it's in color. Right, so things are changing. Their observation, the gain on their sensory functions improves, and this is all has to do with external awareness. So let me show you a video of an example to illustrate some of this. So this is our first ever patient, and she's a lady who was in her 50s, who had been depressed since she was a teenager, and here she is the first day after the surgery, and she's going to tell us, what are you feeling like, and then we're going to turn on. We're not going to tell her. We're going to turn on the stimulator, and you're going to see what happens.
And that sensation of joy, that would be really badass. Things are thinking in this severe ability.
I say 5. Because in many ways, I don't know how to describe it. It's like a nothingness. People talk about the black hole, the black depth of depression, the black hole.
You still on that hole, do you think?
I feel that way. I don't feel, yeah.
So for her, her depression was, she's in a black hole. So now we're going to turn it on. Let me have to turn the volume up here too.
Well, I feel calm and harmony. I'm feeling like I want to smile or laugh or.
This is 4 seconds into this, right?
Everybody's expressions on their faces. And,
You feel more in tune with the group?
Yeah, more in tune with the group, looking at everybody's expressions and.
So we see this kind of response, roughly 3/4 of the patient's immediate response. So what are some of the patients saying? So this is patient number 7. Before the surgery, I had a gnawing agony, a painful self-loathing that consumes all your energy and attention. So we think of depression as a negative thing, but it's actually a positive thing. It's a weight, it's a pain, it's a gnawing, it's a thing. After acutely, we turn it on. It's as though I have suddenly shifted from a state of all-consuming internal focus to realizing that there are a number of things around me to do. Another patient, number 13. When you're depressed, the focus is inward. So if someone tells you you aren't the only one who feels like that, you don't care. With the stimulator on, I don't feel that inward look. It has lifted so that I'm not so focused on myself. The same patient. It's as though I've been locked in a room with 10 screaming children, constant noise, no rest, no escape. Whatever just happened, the children have just left the building. So let me show you over the long term. So this is another patient number 3, and she was in the hospital, had the operation. Then we sent her home for a week to recover without any stimulation. So the video now shows you she comes back to the clinic after 1 week at home without any stimulation, and she's not doing very well because she hasn't had any stimulation for a week.
Well, talking on that relative, I felt a lot better and I felt a lot more confident. I could see a future. But as the week wore on, probably about midweek, I was down at my very worst of my depressions. I was right down there at the bottom and couldn't motivate myself to get up and do anything, just beat on myself because I needed to get some things done around the house and I couldn't seem to get up. I didn't sit and look out the window and beat myself up.
So that's before. This is now a year later.
Well, things are going fantastic. There were things like I couldn't make it down to the main floor to even pick up something and put it away. And now I'm down there working. I've got my own business getting started, and I'm loving every minute of it. Life is great. Looking back over the 7 past years were lost totally in the haze of depression, where I was so immobilized. I couldn't move. I couldn't make plans. I couldn't organize things. Now I enjoy. I make my list. I organize. I get going on things, and I don't know. Life feels really great and normal now. The difference, it's just fantastic. That's all I can say is.
So these stimulators are on 24 hours a day, right? And as we currently use them, the batteries will last for 3 years or so. But we now have also rechargeable systems, so that 1 hour a week you can plug yourself in and get recharged, and the batteries will last for 20 years. So I showed you patient number 1, the acute stimulation. So she started off with a Hamilton of 29 and then was in remission after 6 months. And then the other patient I showed you was patient number 3. She also started with a Hamilton of 29 and then turned out to be at 6 months around a Hamilton of 9. So in our first 6 patients, roughly 2/3 of them responded. We consider a drop in the Hamilton score of 50% or greater to be a response. Of these patients, all of them except patient 1 had ECT. So these are patients that have had multiple drugs, CBT, ECT. If you look at 20 patients now, the yellow line are the remitters and the red line is the proportion of patients that are responders. So we get roughly a 60% response rate, and it takes 1 or 2 months to reach that level and then tends to be maintained. So at the beginning of the first 6 patients, we had roughly 2/3 of them respond, and it looks like even when we have more patients, we still have only 2/3 of them that respond. If you look at the long term, if you respond early at 1 year, you tend to maintain that over time. Remember that these patients have the stimulation ongoing for years. They're going to probably have the stimulation for the rest of their lives, right? So they have it on all the time. But if you responded at 1 year, then at 2 years or 3 years, you tend to maintain that response as well. What happens to their PET scans? So we discovered that at rest, even without making them SAD, they come already plenty SAD, and at rest, their area 25 activity is red, meaning hyperactive, and their frontal lobes are shut down. So the areas in blue are areas where there's decreased blood flow in these depressed patients compared to age-matched controls. And indeed, area 25, the sadness area is overactive, and the frontal lobes appear to be shut down. They're hypofrontal. After stimulation for 3 months or for 6 months, what we see is a complete reversal of this pattern. We're able to drive down the activity of area 25, so we're able to turn down the thermostat from red to blue, and the frontal lobes, which were previously shut down, come back online. We see an increase in the activity of some of these areas seen here. So we're able to completely reverse this metabolic abnormality that is seen in these patients with depression. If one looks at the pattern of changes, it turns out that the decrease in area 25 is something that is common to all psychiatric therapies that improve depression. ECT does this, CBT does this, SSRIs, etc. So if you look at DBS, we're getting an effect which is similar to the drugs here, plus the effects that we get with CBT. I was always amazed that CBT actually produces such a change in the activity of the brain. So CBT actually does produce functional changes in the brain. And with deep brain stimulation, we're getting the cumulative effects of what can be accomplished with cognitive behavioral therapy and SSRIs. So it seems to be an additive effect of what is achievable with these other techniques. If one looks at what are the areas of the brain that change, and you'll see these areas here that change in response to DBS, why is it that these areas change? The reason they change is that they're directly connected to the area that we're stimulating. So we're putting the electrodes here, and I don't know if you can see it, but there are 3 axonal pathways that lead from this area. There's one that's called the cingulate bundle. So when we stimulate the axons here, we're getting remote effects in area 24. There's a medial frontal bundle seen here, and when we stimulate the axons that lead to medial frontal, we get a change in area 10, medial frontal 10, and then we also get the orbital frontal axons, and we see the changes in the orbital frontal area. Not seen here, but at right angles to the screen is the uncinate fasciculus, which projects to the hypothalamus, the brainstem, and the amygdala, and we're also seeing changes there. So the areas of the brain that we see the PET scan changes in are areas that are directly connected and under direct influence of stimulation. So this makes internal sense in that the areas of the brain that change are the areas that are connected to where we're stimulating, the areas where we're stimulating the axons and causing not just the local effects in area 25, but the downstream effects in the projection areas that receive the outputs from area 25. So the way we envisage this then is we're placing the electrodes in this area, but we're having an effect not only locally, but also we're affecting all the pathways, all the highways that lead in and out of this area. In particular, we're affecting the pathways that lead to the cortex, and we're seeing changes in areas that are involved in cognition and action, like orbital frontal areas, dorsolateral prefrontal areas that are connected through these axonal pathways.
We're seeing changes in striatal thalamic channels as well, with nucleus accumbens, the thalamus, and the brainstem, also based on the connectivity. And also we're seeing changes in limbic areas through the projections through the incident fasciculus to the amygdala, hypothalamus, and hippocampus. So by stimulating one area, we're having not only the local effect, but also the downstream effects that are related to the connectivity of this area. With our experience in DBS for depression, we wondered whether this same target could be applied to other disorders. And we decided to place electrodes in the patients with chronic anorexia in the same target that we treat depression. And the reason for that is that depression is prominent in anorexia, and also there are abnormalities in serotonin metabolism in this area in patients with serotonin. So we thought we had enough evidence to go to this area to see if we could modulate Area 25, not in depression, but now in a different population in patients with anorexia. And anorexia, as you know, is characterized by refusal to maintain weight, a fear of gaining weight, and a body perceptual image where, although they are very thin, they don't see themselves as such. Right? So these are some of the fundamental characteristics of anorexia. So we published this in the Lancet a few months ago, and what we did was we chose 6 patients with anorexia, and they had been ill since teenagehood, for most of them, and the average duration of their illness was 18 years. So they had been chronic anorectics for almost 2 decades, and these patients had, of course, tried everything. They had BMIs in the order of 11 or 12 or 13, and interestingly, most of them had comorbid conditions. So, for example, 4 of them had satisfied criteria for major depressive disorder, 1, 2, 3, and 4, and 4 of them also satisfied criteria for OCD. These 4 here, 1, 2, 3, 4. They were on some drugs like this, and they had all been in the hospital for many times. And these patients were so ill that they also had metabolic abnormalities related to hypokalemia. They had heart arrhythmias, gastrointestinal problems, pancreatitis. I mean, they had many medical complications related to their chronic starvation states. And these patients had not had a normal weight for, on average, 18 years. Right? So these are pretty sick patients. They're all women. They're all young women. And this one here, they're all young women. And this one here was our oldest. She was 57. So so what did we do? So we placed electrodes in this area. We turned them on, and this is now a glucose scan. And we saw some of the same findings that we saw in our depression. Namely, we see a decrease in the activity of mediofrontal area, seen here, so area, including area 25. But interestingly, we saw an activation of the parietal cortex. And this is interesting because the parietal cortex is involved in body imaging perception, which is, of course, very impaired in patients with anorexia. So we found that this to be quite interesting, that this area of the parietal cortex had a substantial change after stimulation for 6 months. And again, these are on constant stimulation. So I told you that many of these patients were depressed, so they had an average Hamilton Depression Score in the high teens, and this is what happened to their Hamilton Depression Score over time. It went down considerably, you see here at 6 months, and many of them also had components of obsessive-compulsive disorder as measured by the Yale-Brown white box score, and you'll see that the white box score also improved. What happened to their weights? So this is a graph of their weights over time, and what we found is we operated on them over here, and for the first 2 months they all lost weight, so arguing against any kind of placebo effect. None of them gained weight in the first 2 months, but then after 2 or 3 months we see an inflection, and at 9 months 3 of them had gained weight. 2 of them are normal. I can tell you now that after a year 3 of them had normal weight, and these are patients that have not had normal weight for like 20 years. So a major change in only 3 out of the 6 patients. So it didn't work in everybody, but in 3 of them it did seem to help them. So this is a phase 1 study, and now we are doing a phase 2 study with 20 patients, and there will be a blinded sham assignment where we can assign patients to stimulation on or not for a period of time. So in conclusion then, deep brain stimulation is being used in these psychiatric illnesses. So far, it's quite safe. We haven't had any major problems with this. It's estimated that the main risk we will have is getting a bleeding when we put an electrode in the brain, and then you could die or have a stroke. So that we think will happen about 4 out of 1,000 times. So quite rare, but it's not zero. And it's clear that we can modulate the activity of local and also remote limbic circuits with DBS. And it might be effective in treatment-resistant depression. We're now in the midst of a randomized sham-controlled trial. So this is a trial that will involve 200 patients. We've enrolled 90 so far in the depression trial. We're doing a futility analysis now to decide whether to continue to the rest of from 90 to 200. And in the anorexia, we will continue with a smaller trial again. But we hope that this approach of being able to intervene within these specific circuits in these very ill patients may lead to some benefit in this very difficult to treat population. Thank you very much for your attention.
Any questions? Go ahead.
Lozano, my question for you, I've been thinking about the profile of the patients who receive this, like depressed patients in particular, with these long-term illnesses. What is the impact? I wonder what's the impact for these patients, I mean, those who really improve after 15, 20 years of severe depression? How they make sense of their lives afterwards,
right.
Now that they can,
Yeah, I mean, to some extent, there's a certain amount of forced normalization that takes place because they've been ill for many years. All of a sudden, their symptoms improve. So some of them take it well and start jobs. And this lady I showed you started a business. She opened a cat hotel, so a hotel for cats. So that's But other of them have difficulty coping with the fact that all of a sudden they're, in quotation marks, better. So the burden of being normal is not non-trivial because maybe the rest of their life also has significant problems with their social or family. So it is a non-trivial thing, and we think that it's not sufficient to help their depression, but also they need life rehab in many cases. So it's sort of like having a new hip put in. You have an artificial hip, you have a new hip, but then you'll have to do physio to sort of get used to it and to reintegrate into life. So we think that this is a component of your global life experience, is to take away this oppression of depression, but then you're in a position to respond to rehab and treatment. So it should not be an isolated treatment.
Do you have people who couldn't bear the improvements?
Yeah. So we've had. So I should have told you we had 2 suicides. So we had 2 suicides in people that a week before had Hamilton's in the single-digit numbers. So these are people that were in remission and commit suicide. So what is the pathogenesis of that? Is that impulsivity? Is that they were maybe not as well as we thought? But we've had two suicides in this group. So there's a lot more to this than meets the eye.
Yes, go ahead.
2 questions. One is there any evidence for lateralization in Area 25 with regard to affective processes? And the second is, it appears that DBS, just like ECT and perhaps antidepressants, results in a decrease in activity in prefrontal structures, which to begin with were typically deficient in metabolic activity. And what do we? I never could give a very good explanation for why people who get better show worsening in the frontal cortex.
So a decrease, yeah. So the first question relates to right versus left. So we are starting to get some hints that there is a difference, but I can't tell you exactly what that is. So we have some patients, for example, whose wire no longer works on one side, and then they come in and they say, I was doing well, and all of a sudden I'm terrible, and it turns out that the current is not going on the right side anymore. So then we go in and we fix it, and then they're better again. So we have that kind of anecdotal response. We think that there's quite a bit of bilaterality where we're stimulating. It's right underneath the corpus callosum, and many of the fibers that we stimulate project not just to one side, but to both. So there's that element, that confounding factor as well, that maybe one side is enough. in some patients. So we're not there yet in terms of knowing which side is which. With respect to the activity of the brain as seen in PET scans, what we think is important is not necessarily whether it's high or low, but whether that activity is abnormal and causing disruption in downstream networks. And so in Parkinson's disease, by analogy, when you do imaging of certain areas of the brain, it looks perfectly normal, but yet when you record there, the neurons are firing